Good morning, friends. Myself, Professor Dr. Ketan Mehta, on behalf of Indian Society of Electrocardiology, welcome you for this, our continuation of the series of webinars by a purely learning or academic sessions which we are going to have. Friends, I'm sure all of you are aware about we have been doing this series regularly and we have seen an excellent response from the delegates. Friends, I would like to let you know that all those who are not a member of Indian Society of Electrocardiology, please visit our website www.iacindia.org. You can download the membership form, fill it up, and along with all the documents and the requirements, you can send it to our office. The address, everything is mentioned over there. Friends, this module which we started is the Common Cardiology Care for Clinicians, all 4 Sundays of November, and we had got an excellent response over there. And this was in collaboration with none other than our partner Zydus Cadila, where which has been now in forefront after our Narendra Modi PM had visited the Zydus Cadila office yesterday, and all of you have seen that. And we are waiting for the vaccine to come in the Indian market very soon from Zydus Cadila. All our modules in this common cardiology care for clinicians has got an accreditation from Maharashtra Medical Council. So all those who register for this or are interested, please fill in all the details and you will be entitled for a 1 credit hour per module. I'm sure you must have done it in the previous 3 modules also. Today is the last part of this module, and that is we are going to have a theme of cardiology in pregnancy. It is a very crucial aspect because when we know the cardiology practice, when it comes to the issues in pregnancy, it is altogether a different aspects. And that is how we have also invited obstetrician who would also be interested in managing the aspects of, because this aspect, cardiology in pregnancy, the cardiological issue and in pregnancy has to be managed combined with the obstetrician along with a clinician from medical background. So it was my pleasure to introduce our moderator for today's program, Dr. Uday Jadhav, a near and dear friend of mine, a consultant cardiologist and head at CV Imaging Department, MGM Hospital, New Bombay. He is honorary professor, MGM University of Health Sciences. He is the program director of American Society of Hypertension Scientific Meeting in India for from 2013 to 18. He is also the program coordinator for ACC India Rhythm meetings from 2014 to 19. He has got a lot of publications to his credit, including in the ESH textbook on hypertension, where he has written chapters. He has main areas of interest is dyslipidemia, subclinical atherosclerosis, hypertension, cardiac CT, and CT radiation. His current one review article, which is published in Indian Society of Hypertension Journal, was about hypertension in women. So who better than Dr. Uday Jadhav, who is also the Joint Secretary of Indian Society of Electrocardiology, Honorary Secretary of CSI Mumbai chapter, and the Vice President of Heart Failure Association of India. And above all, an excellent academician and a great human being. So it is indeed my pleasure to welcome Dr. Uday Jadhav. He will take the proceedings forward. Over to you, Uday.
Thank you very much, Ketan. It's been a pleasure, an honor to be invited by you for this meeting. Friends, colleagues who have joined us today morning, I think it's nice to get into a real good clinical cardiology topic of how we look at the aspects of pregnancy cardiology related. I have with me uh, two excellent speakers, both astute cardiologists, interventional cardiologists, great human beings, Dayanand Kumla and Ajit Bhagwat. Having known them over decades, they are uh, absolutely very, very focused on how patients should get the best of care in terms of clinical cardiology. They have a huge experience in terms of dealing with this sort of patients, pregnancy-related cardiac issues, so we'll learn from them. I have with me also panelists, which Ketan will introduce later, but it's an honor to have them all. Professor Dr. Gurpreet S. Wander, a national figure in the field of cardiology, astute teacher. Professor Dr. Muruganathan, it's a pleasure to have him with us. And of course, Ashish Nabar, who has been the president of IIC and one of our very good friends and one of our very good advisors. And you saw how successfully the Rhythm meeting happened in Mumbai recently. Dayanand, of course, is very well known to all of you, leading cardiologist from Thane, from the Jupiter Hospital from Thane, where he's attached. His areas of interest, both in interventional and clinical cardiology, good publication is national journals. Uh, he has been almost a promoter of how cardiology should be taken forward to physicians and how physicians should start interpreting cardiology issues. So it's a pleasure to have Dr. Dayanand with us. Thank you very much, Dayanand, for joining us today morning. I guess we can start, Ketan, with this introduction, and we can invite, you can please invite Dr. Dayanand to take it forward. Thank you.
Over to you, Dr. Kumla.
At the outset, good morning, everyone. At the outset, I should thank Dr. Ketan Mehta for having invited me in this ISC meeting on clinical cardiology for all clinicians. And it's a great pleasure to be here. And I also extend my regards to Cadila over here for having invited me to speak on hypertension and pregnancy. As already Ketan as well as Uday Jadhav have told you that pregnancy and hypertension is a big chapter by itself. So we deal with these patients in and out during our practice and how to treat hypertension and pregnancy. Not only that, I think nowadays when the women become pregnant at the elderly age, they have more problems because they already have hypertension pre-existing, and how to deal with those drugs when they become pregnant. It's a big issue by itself. Hypertension and pregnancy. Hypertensive disorders in pregnancy affects 5 to 10% of pregnancy worldwide, and the major cause of maternal, fetal, and neonatal morbidity and mortality. Maternal risks include placental abruption, stroke, multiple organ failure, and disseminated intravascular coagulation or DIC. The fetus is also at a high risk of intrauterine growth retardation. 25% of cases of 25% of cases of preeclampsia, prematurity in 27% cases of preeclampsia, and intrauterine death 4% of cases with preeclampsia. So there is fetal loss as well, and maternal risk also includes when a patient is pregnant. Prevalence of hypertensive disorders of pregnancy and its maternal outcome in a tertiary care hospital in Tamil Nadu, where they found types of hypertensive disorders: gestational hypertension, 962, that is around 47.4%, preeclampsia, 32.6%, chronic hypertension, 8.2%, and preeclampsia superimposed on chronic hypertension, 11.8%. So, chronic hypertension, which is before pregnancy, is hardly 8.2%. But as age advances in pregnancy, I think the chronic hypertensive patients would be more. American College of Obstetricians and Gynecologists have classified hypertensive disorders of pregnancy into 4 groups: gestational hypertension, preeclampsia, chronic hypertension, and preeclampsia superimposed on chronic hypertension. What is gestational hypertension? Systolic blood pressure more than 140 millimeters of mercury, or diastolic blood pressure more than 60 millimeters, more than 90 millimeters of mercury, measured on 2 occasions of 4 to 6 hours apart after 20 weeks of pregnancy, in absence of proteinuria or systemic signs of and symptoms. So this is after 20 weeks of pregnancy. If patient has hypertension, systolic more than 140, diastolic more than 90, and there is no proteinuria, then it is called as gestational hypertension. Preeclampsia, systolic blood pressure more than 140, diastolic more than 90 with proteinuria or without symptoms, systemic signs and symptoms of eclampsia or preeclampsia and convulsion. Chronic hypertension, systolic blood pressure more than 140, diastolic more than 90, present pre-pregnancy or less than 20 weeks of gestational age. This is chronic hypertension. Preeclampsia, everybody knows there is increased blood pressure, new onset proteinuria, end organ dysfunction, in addition to pre-existing hypertension, where you have this preeclampsia in already existing hypertension. Latest guidelines, 2020 ISH Global Hypertension Practice Guidelines, which was published on 6th May 2020. Hypertension pregnancy diagnosis and management of NICE guidelines published in 2019, and ESC and ESH 2018 guidelines for the management of arterial hypertension. At the same time, we know Dr. Uday Javadav has written a very good article on pregnancy and hypertension, which we have all read about it. Hypertension in pregnancy. BP measurement is a big thing. BP measurement in pregnancy. Use either office manual auscultation or an office automated upper arm BP device validated specifically in pregnancy. This particular thing is very useful for measuring blood pressure in these patients. Optimally, use either 24-hour ambulatory BP monitoring or home BP monitoring validated in pregnancy to evaluate white coat hypertension. As everyone is aware, when the patient comes to our clinic, the blood pressures are more on the higher side. This is called as white coat hypertension. So you can tell these patients to have home BP monitoring or use 24-hour ambulatory BP monitoring to diagnose these patients whether they are hypertensive or not. As it is very common now in the pandemic of coronavirus, today you find most of the patients at home have thermometers or pulse oximeter, oxygen saturation, heart rates are measured. Even a person has a BP monitor at home. As it's a very simple device, so just you can roll it around your arm and click the button, and so you get systolic, diastolic blood pressure as well as the heart rate. Investigations in hypertension in pregnancy. Very essential: urine analysis, complete blood count, liver enzymes, serum uric acid, serum creatinine, which tells us what is the status of the kidney function and what is the status of the liver in patients who are hypertensive during pregnancy. Test for proteinuria in early and second half of pregnancy. This is for preeclampsia. In positive urine dipstick show followed with a spot urine albumin creatinine ratio. Optimal would be ultrasound of kidneys, and maybe we might extend it to renal Doppler as well. If a person's blood pressure doesn't come down and you find he has got very high blood pressure, then I think that lady should undergo renal Doppler as well, and Doppler ultrasound of the uterine arteries as well. So there are certain patients who have got maybe arthritis where you can have uterine arteries getting involved as well if a patient is hypertensive. Hypertension in pregnancy, diagnosis and management, NICE guidelines, where we are reducing the risk of hypertension disorders in pregnancy, proteinuria in hypertension disorder of pregnancy, management of chronic hypertension in pregnancy, gestational preeclampsia, fetal monitoring, intrapartum care, and medical management of severe hypertension are all discussed over here. Hypertension in pregnancy overview. Suppose a woman who is pregnant or planning pregnancy. Pre-pregnancy advice for women with treated hypertension. So you have to be very careful. Somebody who is just married and in the age group of 25 to 30 has mild hypertension. So be careful in choosing the drugs or pre-pregnancy advice for women with treated hypertension. Second would be reducing the risk of hypertension before and during the pregnancy. So you have to see that the blood pressure should be controlled before the female conceives. Managing hypertensive condition during pregnancy is also very important. So always bring down the blood pressure. Ideal blood pressure and ideal goal should be achieved during pregnancy. Whereas if we have chronic hypertension or gestational hypertension, preeclampsia, all these things we will be discussing. For severe hypertension, severe preeclampsia and eclampsia in a critical care. NICE pathway on medicines optimization and NICE pathway for adults with hypertension are also discussed. Reducing the risk of hypertensive disorders in pregnancy. So advise pregnant women at high risk of preeclampsia to take 75 to 150 milligram of aspirin daily from 12 weeks until the birth of the baby. Now aspirin, you know, in cardiology practice or neurology practice or in a general medical field also, aspirin is advised as an antiplatelet agent, one who suffers from, say, myocardial infarct or suffers from stroke. But here, this particular aspirin is preventive for preeclampsia and also until the birth of the baby, one can use 75 to 150 milligrams daily from 12 weeks until the birth of the baby. Women at high risk are those with any of the following, like hypertensive disease during a previous pregnancy, chronic kidney disease, autoimmune disease such as systemic lupus erythematosus or antiphospholipid syndrome, type 1 or type 2 diabetes, and chronic hypertension. These are the people who are at high risk. Advise pregnant women with more moderate risk factor for preeclampsia, 75 to 150 milligram aspirin daily from 12 weeks until the birth of the baby. Factors indicating moderate risk are first pregnancy, age 40 years or older, pregnancy interval of more than 10 years, BMI of more than around 35, family history of preeclampsia, and multifetal pregnancy. Do not use the following to prevent hypertensive disorder during pregnancy, like nitric oxide donor, progesterone, diuretics, and low molecular weight heparin. Management of chronic hypertension in pregnancy. Advise women who take angiotensin converting enzyme like ACE or ARBs, they have an increased risk of congenital abnormalities, so these drugs have to be avoided. At the same time, discuss alternative antihypertensive medicine with the care professional or to guide the family doctor to see that they don't use all these drugs which could be teratogenic to the fetus. To discuss alternate treatment with the healthcare worker for managing their hypertension, ACE or ARBs are already existing in their particular armamentarium. Stop antihypertensive treatment in women taking ACE or ACE if they become pregnant, preferably within 2 working days of notification of pregnancy. Advise women who take thiazide or thiazide-like diuretics, which may also increase the risk of congenital abnormalities and neonatal complications of these drugs when they are taken during pregnancy. Treatment for chronic hypertension. Continue with pre-existing antihypertensive agents. Treatment is and see that they are safe during pregnancy, and one should see that the systolic blood pressure is less than 110 or sustained diastolic pressure is less than 70. Woman has if she is having symptomatic hypertension, then please control the drugs and use the drugs accordingly. Offer antihypertensive treatment to the pregnant women who have chronic hypertension who do not already are under treatment. Then you have to see that their blood pressure, systolic and diastolic, have to be maintained well. Consider labetalol to treat chronic hypertension in pregnant women. Consider nifedipine for women in whom labetalol is not suitable, or methyl-dopa. If both labetalol and nifedipine are not suitable, then you can use methyl-dopa. Base the choice of any pre-existing side effect profile risks, including fetal effects and women's preference. So that is very important. And offer pregnant women with chronic hypertension aspirin 75 to 150 milligrams once daily from 12 weeks onwards. Timing of birth. Do not offer planned early birth before 37 weeks to women with chronic hypertension blood pressure is lower than 160 by 110. For women with chronic hypertension, blood pressure is lower than 160 after 37 weeks without antihypertension. Timing of birth and maternal fetal indication for birth should be agreed between women and a senior obstetrician. So that also is very important when you will plan timing of the birth in this particular fetus and whose mother has got hypertension. In postnatal investigation, monitoring and treatment. In women with chronic hypertension who have given birth, measure blood pressure daily for the first 2 days after birth, at least once between 3rd and day 5 after birth, as clinically indicated if antihypertensive treatment is changed after birth. In women with chronic hypertension during birth, aim to keep blood pressure lower than 140 by 90. Continue antihypertensive treatment and offer a review of antihypertensive treatment 2 weeks after the birth. The general practitioner or specialist can give drugs accordingly. So, woman has taken methyl-dopa to treat chronic hypertension during pain. Stop within 2 days after the birth and change to an alternative antihypertensive medicine treatment, because at times it has been found patient may go into depression. Management of gestational hypertension. Degree of hypertension like 140 by 90 or 159 by 109 may not require admission for any management. Offer pharmacology treatment if BP remains above 140 by 90. Aim for BP of goal of between 135 by 85 or less. Once or twice a week, depending on the BP measurement, and dipstick proteinuria also should be seen once or twice a week with the BP. Those who have got severe hypertension, blood pressure more than 160 by 110, admit them and see that BP falls below 160 by 110. Offer pharmacological management to these patients. Aim for BP goal again 135. Then BP has to be measured every 15-30 minutes when they are admitted, and proteinuria should be checked daily in these particular patients. Consider labetalol to treat gestational hypertension. Consider nifedipine for women in whom labetalol is not suitable, and methyl-dopa if labetalol and nifedipine are not both suitable. Base the choice on side effect profiles released during fetal effects and a woman's preferences. So again, here we have to be very careful in giving medication to a pregnant woman, where you have to see that the blood pressure doesn't fall too low or should not be teratogenic to the fetus. I know it's a big challenge to treat pregnancy with hypertension. You have got limited number of drugs, so you have to be very careful using those drugs. Other drug which many times can be used is hydralazine, nefresol, to bring down the blood pressure. Do not offer. This is the same thing, 37 weeks, timing of birth. Postnatal investigation, monitoring and treatment. In women with gestation who have given birth, measure blood pressure daily for the first 2 days after birth, at least once between day 3 and day 5 after birth. As clinically indicated, if antihypertensive treatment is changed after birth, continue antihypertensive treatment if required. Reduce antihypertensive treatment if their blood pressure falls below 138 by 80. If a woman has taken methyl-dopa to treat gestational hypertension, stop within 2 days birth and change to an alternate treatment if necessary. Prevention of preeclampsia, again, use of aspirin, use of oral calcium, increased risk of pregnancy, first pregnancy if more than 40 years of age, pregnancy interval more than 10 years, BMI more than 35, chronic hypertensive, diabetic, CKD, autoimmune disease, hypertension in previous pregnancy or family history of preeclampsia. One has to be careful where they have increased risk of developing eclampsia. Management of preeclampsia, again, admission to hospital, antihypertensive pharmacological treatment, offer if BP remains above 140 by 90, and those with BP more than 160 by 110, we have to be very aggressive in treating these patients. Again, pre-eclampsia, you can use labetalol, nifedipine, or methyl-dopa. There is a choice of any pre-existing treatment risk, including fetal effects and the woman's preference. Initiate drug treatment, hypertension in initiate drug treatment if BP persistently more than 150 by 95 in all women, greater than 140 by 90 if gestational hypertension or subclinical hypertensive related organ damage is seen. First line drug therapy options like methyl-dopa, beta blockers, labetalol, and calcium channel blockers. If systolic BP more than 170 millimeter of mercury or diastolic more than 110 millimeter of mercury, and it's an emergency, so immediately hospitalize the patient. Start IV labetalol. Then one can use nicardipine, ismolol, hydralazine, and urapidil for oral methyl-dopa or DHP CCBs. Magnesium in patients with preeclampsia, use magnesium. If pulmonary edema is there, then IV nitroglycerin to bring down the blood pressure. Now, what about this? Timing of birth, record maternal and fetal threshold for planned early birth before 37 weeks in women with preeclampsia. Threshold for considering planned early birth could include any of the following known features of severe preeclampsia. You know, once you deliver the child, the blood pressure comes down. So one has to really time that delivery and see that once the baby is out, the blood pressure also comes. Blood pressure can be controlled. So basically, it's inability to control maternal blood pressure despite using 3 or more classes of antihypertensives in appropriate doses. Maternal pulse oximetry less than 90. Progressive deterioration in liver function, renal function, hemolysis or platelet dysfunction. Ongoing neurological features such as intractable headache, repeated scotometers, and maybe convulsions or eclampsia. Placental abruption, reverse end diastolic flow in the umbilical artery, Doppler velocimetry or on echocardiotopography or stillbirth. All these things are very important. Offer intravenous magnesium sulfate and course of antenatal corticosteroids if indicated when the pressures are high and patient is having eclampsia. Now, treat women with severe hypertension who are in critical care during the pregnancy or birth immediately within one of the following, like labetalol, oral nifedipine is the same thing. Intravenous hydralazine can be used to bring down the blood pressure. In women with severe hypertension who are critical care, monitor their response to treatment to ensure that blood pressure falls, to identify adverse effects for both the woman and the baby, to modify treatment according to the response. Consider using of 500 ml of crystalloid fluid before at the same time as the first dose of intravenous adrenaline in the antenatal period. So adrenaline can be used IV adrenaline to bring down the blood pressure during preeclampsia or eclampsia. Likelihood of recurrence of hypertensive disorders of pregnancy. Supposing there is a prevalence, what are types of hypertension? Preeclampsia and late gestational hypertension. So in most of these patients, if the hypertension, approximately 20%, 1 in 5 women, or approximately 2 more than this, which was studied. So gestational hypertension and chronic hypertension, where you have the incidence of problems could increase. So the recurrence of hypertension could occur. If a patient has hypertension during first pregnancy, there is always a chance that the second pregnancy also, or hypertension, she can have a recurrence of hypertension. Same is the case with eclampsia as well. Now, risk of future cardiovascular disease, any hypertension, pregnancy, preeclampsia, gestational, or chronic hypertension. Cardiovascular risk definitely increase. Risk increase up to about twice in patients who have got hypertension during pregnancy. If a patient has got preeclampsia, then the risk is increased by about 1.5 to 3.5 times. Then with gestational diabetes, gestational hypertension, again risk is increased approximately 1.5 to 3 times. Same is the case with chronic hypertension as well. Cardiovascular mortality goes up in patients who have hypertension with pregnancy. It is about twice. In patients with preeclampsia, again, it's about twice of when she delivers. Maybe in future, she can have cardiovascular mortality. But at the same time, stroke incidence is also increased in patients who have hypertension during pregnancy. And even lipid abnormalities have been noted in these patients when they deliver, when they have got chronic hypertension during pregnancy. In future, they can have dyslipidemias, and even certain people do develop diabetes as well. Management of hypertension in pregnancy. ES 2018 ESC and ESA guidelines for the management of arterial hypertension. In women with gestational hypertension, pre-existing hypertension, or superimposed by gestational hypertension, or with hypertension, subclinical organ damage, or initiation of drug treatment is recommended when systolic BP is greater than 140 and diastolic is more than 90. It's class 1 indication. In all other cases, initiation of drug treatment is recommended when systolic BP is greater than 150 and diastolic more than 95. What are drugs? Methyl-dopa, labetalol, calcium channel blockers are the drugs of choice for treatment of hypertension in pregnancy. ACE, ARB, direct renin inhibitors are totally contraindicated during pregnancy. About methyl-dopa, it is nowadays becomes a very, it's a rarity-like drug to get in the market, methyl-dopa, which originally we used to use left and right in patients with pregnancy, as well as patients having chronic renal failure with very severe hypertension. Methyl-dopa is a beneficial drug, very good drug to control the blood pressure. Labetalol is available oral as well as injectable labetalol is available. As even I told you about hydralazine, eprisol, on which is again a drug which can bring down the blood pressure during pregnancy. So our hands are tied when the patient is pregnant, and you have to use antihypertensive agent. So you have to be very careful whenever you are using all these drugs. Either you have to think of the mother as well as the fetus. You should not have fetal anomalies when you use strong antihypertensive medication. At the same time, bringing down the blood pressure too low also could cause fetal damage, or even fetal bradycardias are also very dangerous if you use a lot of beta blockers in these patients. Management of hypertension in pregnancy, guidelines for the management of arterial hypertension. Systolic BP more than 170 and diastolic more than 110 millimeter of mercury in a pregnant woman is an emergency. Admission to hospital is recommended. That is class 1. In severe hypertension, drug treatment with IV labetalol or oral methyl-dopa is recommended. Recommended treatment of hypertensive crisis is IV labetalol, nicardipine, and magnesium. Nicardipine, we know it's again an injectable calcium channel blocker like nisaldipine, nicardipine are used. In preeclampsia associated with pulmonary edema, nitroglycerin given as an IV infusion is recommended. We know that patients who have very severe hypertension can develop pulmonary edema. At the same time, there are studies where they have done echo and found, and they have seen the right ventricular pressures also go up, and patients do develop pulmonary hypertension when their blood pressure goes up, either during eclampsia or preeclampsia. In a woman with gestational hypertension or mild preeclampsia, delivery is recommended at 37 weeks. As I told you, once the baby is out, your blood pressure is controlled. It is recommended to expedite delivery in preeclampsia with adverse conditions such as visual disturbances or hemostatic disorders. You know, during pregnancy, the coagulation abnormalities are known. Either you have DIC or you have thrombotic situation during pregnancy. Thank you. Ketan.
Thank you, Dayanand. Thank you very much.
Yeah.
Ketan will go ahead with the next speaker, please. Dr. Ajit will be doing the second presentation. Ajit is the president of our Indian Society of Electrocardiology. So this year we have wonderful activities. Ketan as the secretary and Dr. Ajit Bhagwat as president, and Ashish Nabar, of course, as the past president. We have had a lot of good academic sessions for clinicians. Ajit Bhagwat is the director of Cath Lab at the Kamlana and Bajaj Hospital in Aurangabad. And again, a very astute clinician, excellent researchers, contributions in some of the important journals, including SERG, JAG, JAMA, the American Heart Journal. And today we will be discussing a very important topic of peripartum cardiomyopathy. There is a lot of learning that's coming. So Ajit, thank you. Can you please go ahead and do the presentation?
Can you all see the screen?
Yes, Ajit, we can see it.
All right. Good morning, everybody. Thank you, Uday, for your kind introduction. After the talk on hypertension, I will be talking about peripartum cardiomyopathy, which is an important cardiovascular disease associated with pregnancy. Now, way back in 90s, when I was in the US, I was involved in running a pregnancy clinic in our Department of Cardiology at Cincinnati. And then at that time, I had the opportunity to write a chapter on heart disease and pregnancy with Professor Peter Engel in cardiology clinics of North America in 1995. Unfortunately, after I returned to India, I could not pursue this interest in pregnancy and heart disease, but nevertheless, I continue to, pregnancy and heart disease continues to fascinate me. And when we talk about peripartum cardiomyopathy, I think it's important to remember that it occurs in pregnant women after the age of 30, presenting in late pregnancy or early puerperium, and it has got a substantial morbidity and mortality. Now, I can certainly say that it's really heart-wrenching to see a young woman who has recently delivered a baby, who is panting with air hunger, with a little baby in her hand. It's really difficult for everybody, for the doctor as well as the patient and their family. Unfortunately, the prognosis in these patients and the chances of recurrence are also significant, and we'll talk about it. Now, there are different terms used for peripartum cardiomyopathy in the past, like toxic cardiomyopathy, Meadows syndrome, Zaria syndrome, postpartum myocardiosis. However, those terms have been abandoned, and now we use a common term of peripartum cardiomyopathy. So what's the definition? It's heart failure which occurs towards the end of pregnancy or within first 5 months of the puerperium following delivery. There is absence of any other identifiable cause for the heart failure, and the LV systolic function is less than 45%. The left ventricle may or may not be dilated. Now, interesting epidemiological part that we can see here, that the prevalence or incidence of peripartum cardiomyopathy varies widely, to like 1 in 20,000 live births in Japan to 1 in 100, as high as 1 in 100 in Nigeria. Look at the difference, and look at such a high incidence in Nigeria. And it is very interesting that if you correlate this incidence with uh, the maternal mortality, it is directly proportional. It is so interesting to see this graph that on the right side you have the incidence of peripartum cardiomyopathy, on the left you have incidence of the maternal mortality, and the incidence of peripartum cardiomyopathy is directly proportional to the maternal mortality in a given country. It's important to discuss the Nigerian story. The locals use a peculiar salt called kanwa after delivery, and it is supposed to cause hypervolemia and hypertension, and leading to cardiomyopathy, in addition to their genetic predisposition. So it's not the salt alone, but they also have a genetic predisposition to cardiomyopathy, and we'll talk about it in subsequent slides. Now, what about etiology? Now, there are a number of etiological factors which have been postulated. So, in short, we don't know what the exact etiology is. It could be multifactorial, but the proposed common final pathway is enhanced oxidative stress. And when the pregnancy advances, the myocardium does not get adequate vascular supply because of reduced neoangiogenesis, and this results in cardiomyopathy. Now, why does it happen? The postulates are inadequately understood, but it may have something to do with prolactin metabolism and impaired vascular growth factors, resulting in reduced angiogenesis. Now, this is called angiogenic imbalance, which occurs in these patients who are predisposed to develop cardiomyopathy. Now, why preeclampsia and multiple gestations these patients are at risk? Because during late gestation in these patients, the VEGF inhibitors such as tyrosine kinase are in high levels in these patients with multiple gestation in preeclampsia. So again, because of these factors like tyrosine kinase, there is reduced secretion of VEGF and reduced angiogenesis in these patients. What is the role of prolactin? This is again, there is a lot of talk about prolactin in this, not completely understood. But again, what happens is there is abnormal metabolism of prolactin, resulting in certain metabolites, which again results in anti-angiogenic effects. And these metabolites are something like 16-kPRL, and there are different fancy names for this, which we may not get into the details of. Suffice it to remember that it's basically an environment where newer blood vessels cannot develop or grow in these patients. Now, if you really look at this graph, what is the incidence of peripartum cardiomyopathy? It coincides with the levels of increase in cardiac output, as well as the levels of these anti-angiogenic factor levels in the blood. So it goes hand in hand. This is an important side which can probably tell you that these factors are probably leading to or producing a causative role in the development of cardiomyopathy. Inflammatory cytokines are also increased in some of these patients, like TNF alpha or interleukin 6, a C-reactive protein, but their exact causative role is not known. Now, what about myocarditis? Myocarditis, again, an important postulation here, and this has been shown now recently on cardiac MRs. There is evidence of inflammation in these patients. Some of the patients have very typical inflammation, and there is this, in certain small studies, interstitial inflammation and associated viral genome were also detected in almost 1/3 of the patients. Another postulation is immune response. So some of the fetal cells, they escape into the maternal circulation, and they remain there without being rejected due to weak immunogenicity of the paternal haplotype of the chimeric cells. Now, if these cells lodge into cardiac tissue, they can trigger a pathological autoimmune response resulting in cardiomyopathy. So this is another postulation. What about genetic predisposition? Now, I'm not getting into the details of this because these are a little complex, but almost 2/3 of the identified patients of peripartum cardiomyopathy have a variant, a polymorphism in the gene which encodes a sarcomere called titin. Now, this is seen in very, very consistently in close to 60% of the patients with peripartum cardiomyopathy, and has been postulated to cause cardiomyopathy in these patients. Certain muscular dystrophies and peripartum cardiomyopathy are associated with each other. So, like Duchenne muscular dystrophy, Becker muscular dystrophy, and Danon disease, these entities are associated with peripartum cardiomyopathy in more frequently in clinical practice. What are the risk factors for development of peripartum cardiomyopathy? Now, age more than 30 years at the time of pregnancy, African descent because of the gene which I showed you, pregnancy with multiple fetuses, a history of preeclampsia, eclampsia, and postpartum hypertension, maternal cocaine abuse, smoking, long-term oral tocolytic therapy with beta-adrenergic agonists such as terbutaline, diabetes, selenium deficiency, and multiparity. These are some of the risk factors of peripartum cardiomyopathy. Now, as I mentioned earlier, they rarely present before 36 weeks of gestation. They usually present during the first month postpartum, but they can present as late as 5 months postpartum. 1/3 of women who presented preterm, 30% women present preterm, and out of them, almost 1/5 have had a diagnosis of cardiomyopathy in a previous pregnancy. So 20% of the patients who present preterm have history of cardiomyopathy in previous pregnancy. Pregnant women with other types of cardiac disease like ischemic, valvular, myopathic may present earlier in the antepartum period because of increased hemodynamic burden imposed by the gravid state during the second trimester. Now, what are the signs and symptoms? They are no different from our routine patient of congestive heart failure. The signs and symptoms are no different. The only caveat is it may become a little difficult to diagnose heart failure in patients late in pregnancy because they have got higher blood volume and increased cardiac output, and certain features like a little bit of elevated jugular venous pressure, a venous hum, sometimes their orthopnea because of gravid uterus, little bit of pedal edema could be confusing and needs to be remembered when you're interpreting signs of heart failure in these patients. Now, how do you diagnose peripartum cardiomyopathy? Basically from symptoms and clinical features of heart failure, but there are certain markers. All these markers are not very specific or sensitive for diagnosis of peripartum cardiomyopathy per se. They will diagnose heart failure, but there is one marker which is called MIR-146A, which is a novel biomarker for peripartum cardiomyopathy, and it is seen in higher percentage of patients with PPCM as compared to women with idiopathic dilated cardiomyopathy. Now, ECG could be pretty non-specific, showing features of left ventricular hypertrophy, non-specific STT wave changes, sometimes bundle branch blocks in white QRS. So, I mean, there is no particular specific feature of peripartum cardiomyopathy which differentiated from the other forms. Now, what about treatment? Again, treatment part is not different, except when you are using drugs during pregnancy and during lactation, you have to know certain things which you cannot use. But otherwise, acute and chronic treatment remains pretty much the same. You use oxygen diuretics during acute treatment. Like some patients have, some authorities have mentioned about anticoagulation in these patients because pregnancy is considered to be thrombogenic, but there are no definitive recommendations about it. In chronic treatment, again, you have diuretics, RAS blockade, beta blockade, anticoagulation, CRT, AICDs, and heart transplant. So the basic principles of treatment of peripartum cardiomyopathy remain the same. There are some specific caveats which we will talk about. Now, diuretics are the agents of choice for volume control. ACE inhibitors and ARBs can be used postpartum, but they are contraindicated before delivery. So don't use them during late delivery when the patient presents.
You got on the mute mode. Please check Ajit again, the audio video.
I think, sir, Ajit sir's network is down.
Maybe call Dr. Bhagwat and ask him, otherwise let him present later after the discussion.
Okay, in case Ajit is not able to join now, when we start the panel, I'll make it a point to ask Ajit aspects of peripartum from cardiomyopathy from the point where he is left off, right? That's the drug therapy onwards. So you always have opportunity to ask him questions, even if the video doesn't come on. But please contact him once and then we take a call.
Ajit sir has joined.
So who is finally telling us whether Ajit will be continuing or the panel should come on? So either Ketan, can you please figure it out?
I have no
Let us
idea
know.
at what point I lost you, but
Okay.
I'm back.
You were on the treatment slide, so you can start.
I was in the treatment side. Can you? You just 1 second. There was. Okay. Can I see the slides? Can you see the slide?
Yes.
We can see the slides.
Okay, so the treatment part, the basic principles of treatment remain the same. There is no difference, except use of certain drugs which are contraindicated in late pregnancy and during lactation. So we'll talk about that. Just go back a little bit. Yeah. Now, ACE inhibitors and ARBs should not be used during pregnancy when the disease is diagnosed in late pregnancy. Beta blockers, they can be used. They're considered safe during pregnancy, but labetalol, which we talked about during hypertension discussion, it has not been tested in heart failure, so it should not be used. Our regular beta blockers like bisoprolol, carvedilol, or bisoprolol, they may be used. But metoprolol is the favored drug in view of more extensive clinical experience. What about prolactin inhibitors? That's something which is important, but we still don't know. It is still controversial whether it should be used because it's an inhibitor of prolactin secretion. And we saw earlier that abnormal prolactin metabolism is one of the contributing factors to pathophysiology of peripartum cardiomyopathy. Now, there are a couple of studies which I would like to quote here. There was one published in Circulation in 2010. It's a very small study with 20 women where they were randomly assigned to receive either standard therapy versus bromocriptine. But the interesting thing was, out of 10 women who were receiving bromocriptine, they showed very significant improvement in LVEF from 27 to 58 as compared to 27 to 36 in placebo. So the result is very impressive, but the number of patients is very small, and it's it's a very, very small study. There was another study from Germany, which enrolled 63 patients with peripartum cardiomyopathy. And again, placebo versus bromocriptine. Actually, it's not placebo versus bromocriptine. It was short-term bromocriptine versus bromocriptine, which was given on the long-term basis. And they saw that, there are significant improvement in both groups, but the frequency of full recovery was nominally, but not significantly higher in a long-term bromocriptine group. So the experience and knowledge about bromocriptine is not adequate, still controversial, but in a desperate situation, one can use it because there are small studies which show benefit of this particular treatment. Now, what about the delivery and breastfeeding? Timing and mode of the delivery, it needs a multidisciplinary approach. Peripartum cardiomyopathy with the compensated heart failure, they can deliver vaginally. Cesarean section is generally reserved for obstetric indications. Epidural anesthesia is preferred. Early delivery is not required if maternal and fetal conditions are stable. Breastfeeding should be avoided due to potential effect of prolactin subfragmentation. And many times these people who are, if they are already on bromocriptine, their lactation is significantly suppressed. Some data about immunosuppressive agents, it's not something which is recommended routinely, but again, there are anecdotal cases and small studies which show benefit, and they might be useful in people where you can clearly show myocarditis on cardiac MR. What about drugs which during breastfeeding? Spironolactone, atilinol, or diltiazem and nifedipine should be avoided during breastfeeding. And these drugs like warfarin, ACE inhibitors, beta blockers, during lactation they can be used. Beta blockers except atenolol, even lanoxin can be used. The important thing about prognosis, because this is what one needs to know when the patient comes to you for advice, sometimes with a past history of cardiomyopathy. Now, important to remember that 50% of the patients make complete recovery. About 25% the patients have persistent symptoms, and 25% develop complications like progressive heart failure, arrhythmias, strokes, thromboembolism, etc. The mortality is close to 3 to 10%. And patients with persistent cardiomegaly after 6 months, the mortality rate is pretty high. It's almost 80% in 5 years. So it's useful to differentiate differentiate them into two groups. One with persistent LV dysfunction, where the chances of relapse are very high. 50% will show further deterioration in LV dysfunction with increased mortality and morbidity with subsequent pregnancy. So if you have a patient who has history of peripartum cardiomyopathy and now she has come to you for advice for subsequent pregnancy, and if you see that she has persistent LV dysfunction, even if it is mild, it's a big no in terms of advising subsequent pregnancies, because the frequency of deterioration is very, very significant with high morbidity and mortality. Now, even if patient has completely recovered from the previous cardiomyopathy during pregnancy, 20% can have relapse during subsequent pregnancy, and 20% is not a small number. And this decision of having another pregnancy should be a shared decision between the patient, husband, the family, and the doctor. And they should clearly understand the risk of getting into another pregnancy. So in conclusions, I would like to say that peripartum cardiomyopathy is pregnancy associated with which presents after 36 weeks and before first 5 months after delivery. Its etiology is unclear, with postulated mechanisms like abnormal prolactin metabolism, anti-angiogenesis and oxidative stress, inflammation, immunological and genetic factors. Presentation and treatment, like it's treated and presents like any other heart failure but you need to remember about some precautions while using certain drugs during pregnancy and lactation. Recurrence rate with subsequent pregnancies is insignificant, and future pregnancies should be discouraged. Well, thank you for your patient hearing.
Ajit, it's been really a pleasure, and we still could cover the whole topic the way you wanted it. So very nice. Thank you very much. we have two sets of instructions as Ketan has informed us. One, we will have a panel discussion and following that, there will be a quiz. So we have a lot of interaction now. I did look at some of the questions that came up and they're all interesting. So as I start the panel, and I welcome Professor Dr. Gurpreet Wander once again, Dr. Muruganathan and Dr. Gurunath from Sholapur. Let me start. Gurunath, of course, is one of our leading cardiologists from the state of Maharashtra. He has his own hospital and he has significant amount of research work and very original work also. So I think that's very important. He did the midterm ICCON for us a year back. Very well versed in interventional cardiology, but excellent clinicians. I've loved listening to his ECG lectures and I've learned a lot from him. So great, we have very good panel with us. And of course, with this panel, both our speakers should also be there. So there will be some pertinent points. What we'll do is, let's have a classroom discussion focused first on hypertension in pregnancy for the first aspect. Second, let's discuss peripartum cardiomyopathy. And then I think we should also discuss some other issues of cardiology related to pregnancy. So let me make a couple of important points when we start hypertension. Starting with hypertension in women, two very important recent papers told us this message is. One of the largest study pertinent, more than 180,000 women which were studied, the incidence of hypertension in the age of 45 and 54 years was reported close to 23.7%. That's quite a large incidence. So that's comment one. Second comment is a paper in very, very big profile, which looks at that because of increased vascular stiffness, women tend to develop hypertension earlier than men, in fact, in the third decade. And the rise in blood pressure as compared to men is much steeper in a linear fashion. Therefore, addressing this whole issue of hypertension in women in general, and very important in pregnancy, as Dr. Dayanand sort of described, is of great relevance. So, let us have our panel on board and let us start a few comments from them.
Can I request if you can introduce the three panelists?
Oh yes, surely. Can you please go? I already introduced Gurunath. Okay. Yeah, we already introduced Gurunath. I think everyone heard that. Can we go to the next panelist, please? Professor Dr. Gurpreet Wander. He is a very astute teacher. He has been one of our most senior cardiology faculty from the country's professor and head of cardiology at the Ludhiana Medical College. He has been president of API in the past. Excellent teacher. We have heard him practically at every important forum in this country. And he has many original contributions, authorships, and guided authorships also. So it's been a pleasure, sir, to have you with us today morning. And also Professor Dr. Muruganathan, may I have his CV, please? He is the Emeritus Professor at the MGR Medical University in Tamil Nadu. He has been the governor for the ACP, the Indian chapter, the dean of the ICP. He has been the president for a hypertension society and the APIs. And again, tremendous amount of interest and insights into the subjects of hypertension. So, sir, it's a pleasure to have you with us and understand and learn your comments on how we go ahead and take it further. May I take a couple of questions? First, Dr. Muruganathan, and then Dr. Wander and Dr. Parale will have the address in those orders so that, we won't have to mute and unmute. The question comes from Dr. Abhijit Trilokya. And he says, Dayanand already said, what in your opinion is the safest drug for treating blood pressure in pregnancy? So Muruganathan, please.
You have to unmute yourself, sir, Dr. Muruganathan.
Mr. Jignesh, we are not able to hear Dr. Muruganathan. Could you just look into it?
Yes, sir. Sir, just remove the headphone. Remove the headphone. Muruganathan sir, remove the headphone.
Okay.
Yeah.
Can you hear me?
Yes, yes. Now we can hear you.
I don't know what is the connection between headphone and the hearing. I have been using headphones so far. I don't know, this is first time. Okay. Medicine is always interesting, like webinar also. You were asking about the safest drug. According to, when we were students and young physicians, of course, still I'm young only, we were using alpha methyl dopa left and right. Now the safest drug, according to the classification A, B, C, the alpha methyl dopa comes under a class B, but we normally use labetalol because alpha methyl dopa is not that effective antihypertensive as labetalol. So first drug we use is labetalol, then followed by alpha methyl dopa and lipideprin.
Okay, fair enough. Thank you. And Dayanand already discussed that in details. Now, Professor Dr. Wander, this is an interesting question. A clinical case which Dr. Urmila from Mumbai says that she has a patient of hypertension in pregnancy who also has atrial fibrillation and is also a known case of bronchial asthma. Now, can you give us a safer drug to use or the better option?
This is actually a complicated situation because we know that pregnancy is a hypercoagulable state, and most coagulation factors are increased during pregnancy. The fibrinolytic process is hindered, and basically whatever our body does actually in any physiological situation is a compensatory phenomenon. And why hypercoagulable state? Because the body has to stop the bleeding which is likely to happen at labor. So that's the reason it's a hypercoagulable state. Now, whenever someone has hypertension with atrial fibrillation, that becomes an indication for anticoagulation. Because if you look at the CHA2DS2-VASc score, and also pregnancy is we know it's a hyperkinetic situation in which the blood volume increases by about 1 to 1.5 liters. So the problem actually with using anticoagulation during pregnancy is that whenever you use vitamin K antagonists in the first trimester, there is a higher incidence of fetal teratogenesis and there is a peculiar embryopathy which happens. So use of anticoagulants actually in the first trimester of pregnancy has to be in the form of low molecular weight heparin. You can switch over to a vitamin K antagonist in the second trimester. But at the time of labor, you will have to again switch on to the heparins because of obvious risk of bleeding during pregnancy. So during the time of labor. So you cannot just leave this atrial fibrillation alone because you are dealing with a situation which itself is a hypercoagulable state, and atrial fibrillation with hypertension is associated with. Good thing that obstetricians do actually is they use actually once a day low molecular weight heparin. They use 1.5 milligram per kilogram body weight of enoxaparin as against 1 milligram per kg body weight of enoxaparin that we use twice a day in acute coronary syndromes. So it's a kind of a decision, I think, which will have to be taken between the mother and the obstetrician. But largely, if the patient is compliant, patient is educated, you will also have to look at the echocardiography. If the LA size is large, patient has left ventricular hypertrophy, all the more reason your patient needs to be on anticoagulants. So the issues with anticoagulants actually I have already discussed, but there is a very good, actually this issue of anticoagulants with pregnancy is more of an issue in patients who have mechanical valves. And there's a beautiful study which came in the New England Journal of Medicine, which shows that whenever warfarin dose is less than 2.5 milligrams per day, the issues related to the embryopathy do not happen. And in that particular situation, you can even continue with the vitamin K antagonists. So those are some of the thoughts that I have on this issue, on this patient.
Especially when you use warfarin, you should see the INR and make sure that INR you kept it in 2.5, and then you should not take 5 milligram of warfarin. Otherwise, it's yes.
Absolutely. Dr. Gurunath, a nice question which comes up here. There are two people who ask.
while we are there at anticoagulation, can I just share my screen and show a couple of slides?
I do not know technically how we are going to go about it, but
okay, I'll just explain. As has been rightly pointed by Wonder sir, that a dose of warfarin, the complications of embryopathy are dose related. Now, the problem is very peculiar, especially because I encounter many patients who have undergone mechanical valve replacement and they undergo pregnancy. And here, as we know, anticoagulation is very, very essential. And just digressing from this hypertension, but I think this would be a very relevant topic to discuss about anticoagulation in those with mechanical valves, because currently I have one patient hospitalized with me with the same problem. Now, the things which we have to discuss, absolutely, they need anticoagulation. There is no doubt about it. Now, the type of the regimen that has to be followed in pregnancy, as has been said by Dr. Wonder sir, that first trimester, as far as possible, you should avoid vitamin K antagonists. The problem is now there have been 3 regimens that have been invoked for anticoagulation in pregnancy. One is using vitamin K antagonist throughout the pregnancy, all 3 trimesters. Second, using heparin in the first 6 to 12 weeks, where there is a maximum chances of warfarin embryopathy. Use heparin in that situation, and rest of the pregnancy you continue with vitamin K antagonist, and again switch over to heparin late at the time of delivery. That's the second. Or third is heparin throughout. Now, the interesting comparison of this I would have liked to show on the slide is you have to discuss in both endpoints. One is a fetal endpoint and second is the maternal endpoint. Now, if you see, there is nearly 25% abortion rate in any of the regimen, whether it is vitamin K antagonist, whether it is heparin throughout, or whether it is a combination of vitamin K antagonist and heparin. So fetal complication of abortion is 25% in all. So that is equivalent. So that goes out. Now we have to see about the maternal complications. Now the maternal complication is thromboembolic, and that is disastrous. As you know, if you have a thrombosed valve, virtually would be fatal. So the maternal complications, thromboembolic complications, are maximum with heparin throughout. Okay, so if you use heparin throughout the pregnancy, maternal thromboembolic complications are very high, and maternal mortality is highest with that regimen. Similarly, the combination of warfarin plus heparin, there's 6 to 12 weeks heparin, and rest of this similarly also has a very high rate of maternal thromboembolic complications. So if you see statistically, as far as mother is concerned, warfarin is the best to continue throughout the pregnancy. It would be very ideal if the dose of warfarin, the therapeutic anticoagulation with warfarin, if it is less than or equal to 5 milligram, the chances of warfarin embryopathy is less than 5%. Okay, so that is acceptable. But still you have many patients where on this dose or those who require a large dose. And in fact, offhand I can cope. I have 3 patients now who have had repeated abortions. With this academic knowledge, I continued warfarin throughout in those patients for the 3, and they had multiple abortions. Now I'm stuck up. What should I do? Now we have some data about low molecular weight heparin. Now, low molecular heparin is the new option that we have. This you can give in the first trimester, or ideally between 6 to 12 weeks, where the incidence of warfarin embryopathy is highest. And this is a bridge between the two. Yes, here this balances with the maternal as well as fetal complications. But the downside is how to titrate the dose. The problem of titrating dose of low molecular heparin is, once you give twice a day, is ideally you have to measure anti-10A levels. And these anti-10A levels have to be measured after 4 hours of administration of low molecular heparin, and that you have to maintain between 0.8 to 1.2 international units per unit, per ml. So now I don't know how many centers can measure this, especially my center doesn't have it. Now, so that titration is very important. So you will either undercoagulating or over anticoagulating this patient. So this is a very dicey situation. But my bet is still continue vitamin K antagonist, especially if you have to use a low dose less than 5. That is one thing. The second question about that atrial fibrillation which the patient has. Now we know flecainide is a drug which is safe in pregnancy. I want to ask
Gurunath, I'm going to interrupt you for a second because we'll have to save time on all this. The question was, the background is of atrial fibrillation and asthma, and she's a pregnant lady and has hypertension in pregnancy. You see, there is a problem about beta blocker. That's my understanding from the question, because the patient has asthma and atrial fibrillation is the other sit-on. So you need to give a drug which helps AFib, does not worsen her asthma, controls her BP. You have 3-4 classes of drugs only for BP control in pregnancy. What would be your choice? So the question is
nifedipine is the only choice which I can think of offhand. Nifedipine, the only thing which I would like to mention about nifedipine in hypertension, the metabolism of nifedipine in pregnancy is slightly different in a non-pregnant women. It is metabolized very fast. The half-life of nifedipine is less in pregnancy. So the frequency of dosage you have to increase in pregnancy.
Absolutely.
That is the thing which I want to make a point here.
Right. Thank you, Gurunath. So now yes, sir.
See, the obstetricians use nifedipine more often, but there is no harm in using amlodipine also, because it's a good drug and it's a smoother blood. See, obstetricians have been using nifedipine for a long period of time. So that is the reason in some of their guidelines, we will still see nifedipine coming. But there is actually nothing in the metabolism of amlodipine also. It can be safely used in such patients. Dr. Uday raised the issue. Yes, labetalol will, in a patient who has asthma, there will be issues in using labetalol, although there will be no issues in using alpha-methyl dopa in such a situation.
Right, sir. Thank you. Now, there has been a little discussion starting, and then Dayanand should also chip in here. When we talk about diagnosis of hypertension in pregnancy, whether it's gestational or a pre-existing, the crux point is we do not want to miss a hypertension in pregnancy, so that our therapeutic strategy is on time and is properly done. Amongst the modalities of blood pressure lowering, when you look at the guidelines carefully, there are two comments I want to make, and then I want the whole panel to comment on it. Between a automated, an aneroid, and a mercury manometer, the variation in readings in aneroids is as high as, for a 10 millimeter variation, is still as high as 50%. And the least variability in terms of defined values is still best with mercury manometers. Automated blood pressure monitors may have a problem about, again, giving you a little lesser reading than the mercury manometer. So you may wrongly continue to label as normotensive. So this is one of the sort of a little unresolved area in the terms of defining blood pressure in hypertension. The other one is ambulatory. And as Dayanand showed, and he will comment again, the 2020 guidelines brings out an important point. Ambulatory blood pressure monitoring is optimal, but not utilized for the diagnosis of hypertension in pregnancy, for the simple reason that the values defined are comparable from non-pregnant stages or non-outcome based values in the normotensives, you see, or rather in the non-pregnant women. Therefore, I want to comment whether mercury manometer is still the best way around, so that we do not underdiagnose hypertension in pregnancy, and whether ambulatory blood pressure, which may be okay for looking at complications in proteinuric patients and preeclampsia, but purely for the diagnosis of gestational and monitoring patient, is it required? We start with Muruganathan, Gurpreet sir, Gurunath, and Dayanand. Please.
Thank you, sir. Now, for the pregnant patient alone, there are validated BP monitors, especially home BP monitors. So I am the one of the person who is promoting home blood pressure monitoring. There are home BP monitors validated among the pregnancy patients, pregnant hypertension patients. That will be ideal. Of course, automated BP monitors also, according to American Obstetric Association, they recommend automated BP monitors validated among BP pregnancy patients. So special validation among the patients can be used Of course, mercury now we are removing. So mercury is ideal, but we don't use mercury. So validated home BP monitor, validated automated BP monitors, and in rare cases like preeclampsia and other conditions where it is possible, we can do APBM.
Dr. Wander, sir.
Yeah, that's a very good point, actually, Dr. Jadhav, you made, and that one needs to dwell upon it, actually. How I look at it is, yes, mercury would be the best. The large dial automated sphygmomanometer, aneroid sphygmomanometers are as good, because if you are using a large dial aneroid, which you are calibrating every 6 months, the problem with the aneroid ones is that they need calibration every 6 months because they are based on a spring. And that spring becomes loose. And if you are not calibrating, a mercury sphygmomanometer you can use without calibration for maybe a couple of years. But the aneroid sphygmomanometer you cannot use without calibration every 6 monthly. The problem is that pregnancy is a hyperdynamic circulation. And also a lot of our patients in India are actually anemic. So there are two factors which are increasing this hyperkinetic situation which happens in pregnancy. And a lot of people feel that the phase 4 of the Korotskov might be more ideal for the phase 5. The problem actually with the oscillometric devices is they have to be actually for the pregnant women as well. And the routine Omron equipments that we have, they are actually have not been calibrated for pregnant women. So if you are using an oscillometric device which measures blood pressure by an algorithm only, because it's not measuring the systolic and diastolic. What the oscillometric devices do is they just measure the mean blood pressure, and by the company-owned algorithm, they derive the systolic and diastolic blood pressures, which are indirect actually derivations. And whenever there is a situation of hyperkinetic situation or a high output state, obviously they need to be calibrated for that also. So there is a need for only using specific and accurate blood pressure apparatuses if you are using oscillometric, which have been looked for the pregnant women also.
All right. Gurunath, your comment?
And nothing more, but I have a bias towards mercury only. I tend to be comfortable using mercury because I hear with my own ears and I feel comfortable diagnosing that. That's it.
Yeah, mainly because, you know, as sir was also mentioning, Professor Gurpreet sir, that we don't have really outcome-based studies with all the other devices in pregnancy. Pregnancy is a peculiar situation and we don't want to sort of, you know, miss hypertension. That's the very reason. Dayanand, you have been the speaker. I want your comment, final comment on this.
Yeah. First thing is that how you measure the blood pressure is also very important in a pregnant lady. Sitting blood pressure is what we measure even in our normal patients as well. So similarly, in pregnant ladies also it has to be sitting blood pressure to be measured. As you said about automated machines, even there are certain blood pressure apparatus which measures 3 readings and then gives an average of systolic and diastolic blood pressure. And this can be applied to the patient's arm, and you can make her sit in one place, then nobody disturbs her. Then you can go and see the reading over there. So that also could be very useful in measuring blood pressure, in particular these patients. And home BP monitoring, as everyone knows, very rarely patients use mercury manometers. It's always either these automated BP apparatus they use. So as in UK, mercury is banned. So similarly, we also will slowly go up. But as Dr. Gurunath Paralai says, he's right. We listen to all those sounds. But as the age advances, I think Korotko sound becomes very difficult for an elderly physician as well. Thank you.
All right. Thank you. The last point now, before we go to peripartum cardiomyopathy, Professor Muruganathan. Dayanand mentioned, and there is plenty of literature, that gestational hypertensives, women in pregnancy, continue to accrue a higher risk, both for developing hypertension, for getting vascular events, for cerebrovascular disease, strokes. How do you follow up? See, what's happening is, one, gestational hypertension is over, or hypertension is pregnancy is over. Drugs are supposed to be reduced and stopped about 6 days. And at 42 days post-labor, blood pressure will revert back to normal. Most of these ladies, we don't even advise them to get their blood pressure checked after that on a regular basis. In fact, we see hypertensive patients, women at the age of 40 or 42 years, and we ask them, do you have a history of gestational hypertension? And they say, yes. We ask them, did you check your blood pressure thereafter? They said, no, nobody told us so. How do you think there should be a process of follow-up? And which is the effective way to reduce the burden of hypertensives and CV events in this class of patient? Professor Muruganathan, and then Dr. Wanda.
Yeah, this is a very, very interesting and a very good question. Because, once the patient is delivered and once the patient leaves the hospital, neither obstetrician nor the physician follow up. Because, it's quite sad, we don't follow. And also, when they come for next time, we must also, what is known as APO, adverse pregnancy outcome. We must ask them whether previous delivery you had a small gestation age or you have IUGR. If the patient gives that history, these are the patients who are going to develop cardiac problem, that ladies. So that also, in the history, people don't ask APO history when they come for the second time. Ideally, every patient when they get discharged, my opinion is ask them to check the blood pressure at home every month at least. First 2 days, every day you must measure. Third, fourth day, that already the previous speaker spoke. But at least once a month, they should measure the blood pressure. And when they discharge, my suggestion is in my patients where they're rich, I always give them a home BP monitor. I add that in my bill and give it to them home blood pressure monitor so that they measure. Unfortunately, we don't have what is known as HIPC. We have DIPSI, diabetes in pregnancy society study in India, whereas there is no hypertensive disorders in pregnancy in India. That's why I was telling Wanda, I was telling other associations, why don't we start a HIPC, a separate body where the physicians and obstetricians come together and form a protocol and follow procedures like this. So there is no such thing. And I'm also I'm very sad to say there is no pure hypertension specialist in our country. Everybody, Uday Jadhav is a very hypertension specialist, but he sees other cases also. And Wander is a very good hypertension specialist, but he does the interventional cardiologist. If you take a diabetologist, they see only diabetology and diabetology only. They don't see any other case. Like that, we should have an hypertension specialist and hypertensionologist. And especially with the obstetrician, they have an association called Gestosis in their obstetric association. We must involve them with the physicians and cardiologists. We must have a HIPC and form a protocol. And what point you have said is very, very valid point, because many patients who are pregnancy hypertension patients, they have developed a lot of complications, they develop problems, they develop stroke, they develop diabetes also. So unless they follow up and then we control the hypertension, it's very, very difficult, because only after 3 years when they come for pregnant, we are asking whether you have checked the blood pressure. So I think this ideal time, we must also promote home blood pressure monitor. Give the home BP monitors to the patient when you get discharged, include in your hospital bill, let them check the blood pressure. This is my way of approach.
Professor Gurpreet sir, you are with the government medical college heading the cardiology department. What is your experience in our medical colleges? Are we following these women a little more carefully over the next 2 decades?
Yeah, you made a great point actually, Uday, and I'm very happy that you did ask, because this actually comes to the moot issue. Gestational diabetes, preeclampsia, as the reason why Dr. Uday is asking is because it is a marker of subsequent strokes, coronary artery disease, increased incidence of hypertension, cardiometabolic disorders. So any women who has had, besides thinking that once the person is in a puerperal period and you can start ACE inhibitors and ARBs, that's another actually factor. Once the lady has delivered, then you can switch over actually if you feel like switching them over to the ACE or the ARBs. But the long-term issue is a much more important issue, because it is gestational hypertension is a marker of subsequent vasculopathy. So these patients have not only higher incidence of hypertension, but they have higher incidence of stroke, coronary artery disease, and all these cardiometabolic syndromes. So long-term follow-up, as Dr. Muruganathan said, and the reason actually you brought this issue is very important for these women.
Right, sir. I think the National Society should set up something together and have a sort of statement on this, so it encourages more people to read and follow it. Thank you. We are going to go ahead with the peripartum cardiomyopathy, and we should be in time then. As I look at the questions that have come and putting it all together, and I'm going to start with Ajit and Gurunath for this. Couple of things that I need to sort of both mention and ask. So I remember having seen a young lady doctor who had a peripartum cardiomyopathy, and as you defined it 1 month prior and then 5 months postpartum. So this definition did have a little change in 2005 because they found even a lady who is 2 months or 3 months prepartum will have absolutely similar features for a peripartum cardiomyopathy as that which is diagnosed 1 month prior. So necessarily the cutoff level of 1 month may not be absolutely necessary. This is a question because when this came up, then I had to look back on the literature and say, is there a guideline? Is there anything telling us something different? One. Couple of other things is that the BNP, anti-pro-BNP levels, besides the age and gender and everything, fortunately are normal in pregnancy. So that helps us pick up a few things early. Preeclampsia only causes a very mild elevation of anti-pro-BNPs. It's only when patients get peripartum cardiomyopathy. So that's the diagnostic point. Third diagnostic point is that we still go by the EF of less than 45%. The LV may not have got dilated. So it's not the size of the LV, but the function of the LV that should decide cardiomyopathy. And thirdly, because we will discuss CMR and Ajit will tell us about it, gadolinium is contraindicated in pregnancy. So one need not do a gadolinium enhanced MR, though LG enhancement helps us. It tells you myocardial fibrosis and patients who will not recover as well as you prognosticated your patient peripartum. With this few short comments, may I invite Gurunath on these aspects. Let's talk of diagnosis of peripartum cardiomyopathy. We keep a classroom discussion. Then we talk about therapeutics and postpartum. Your comments and then Ajit will help us.
Yeah, as you rightly said, now it is the diagnosis basically, as we see, the diagnosis will rest mainly on the symptoms and the this diagnosis will rest on symptoms. And as Dr. Bhagwat had pointed out, because many of the features which are there, the normal pregnancy does have elevated ZVP, hyperdynamic circulation, third heart sound. So the clinical examination may not help. And so ultimately the diagnosis will depend on the marker, that is the anti-pro-BNP as you have suggested, and the echocardiography. Now the ejection fraction, as you saw, most of us label the LV dysfunction on just visual or eyeballing. That's the ejection fraction. That's most of it do on echo. So that marginal 45-50 may change with person to person. When it is gross LV dysfunction, 30%, 25%, there won't be any doubt. But when there is a marginal LV dysfunction, then perhaps you may have to rely more on the history and the marker, that is anti-pro-BNP, for the diagnosis of peripartum cardiomyopathy.
Ajit, your comments, please.
Yeah, I think he has mentioned most of the things, but the problem occurs especially when the LV size is normal, and you have a faint third heart sound. Patient is complaining of mild breathlessness, which could be because of the gravid uterus. You cannot really make out. These are the situations which make the diagnosis a little tricky. But if you even looking at the IVC in this situation, if the IVC is dilated, it doesn't help you. But if it is not collapsing, it helps you. If you have signs of pulmonary hypertension in pregnancy, pulmonary hypertension in pregnancy is certainly, it will give some clue that there is something wrong in the cardiac hemodynamics. So, looking carefully at the IVC, looking carefully at the pulmonary hypertension, and if you have by any chance, if you have a previous echo to compare with, that will be unusual, but that can help you. But as you correctly mentioned, that MRI is contraindicated, especially in LGE you cannot make out because gadolinium you cannot give in pregnancy.
Yeah.
But then that becomes important only when a patient delivers, and then you can do it.
Yes.
And if you see significant degree of inflammation, which in a few patients demonstrate, then use of immunosuppression and steroids might help. I mean, it's not hard and fast, but it might help. But sometimes the diagnosis in these borderline cases could be very, very tricky. But biomarkers could come very handy. As you mentioned, BNP is normal in pregnancy. If it is elevated, anti-pro-BNP, it gives you a clue for heart failure.
Right, Ajit. So there is a question and a comment, and I'll be asking Dr. Wander and Dr. Muruganathan to comment on this. Is that the question came up? So is it necessary to do echocardiography in all pregnancies? Dr. Vittal Narvate asked this question. May I make a comment and then we will take this? That it's interesting to see, if you look at peripartum cardiomyopathy, who are the patients who develop it more between a normal and a pre-eclamptic? The pre-eclamptic will have it a little more. So one of the, the Jack had a publication recently saying that you can do a speckle strain imaging, do a strain imaging, which is completely non-invasive echo art. So do a strain imaging in pregnancy, and that will pick up subtle myocardial abnormalities and the sort of a precursor to develop peripartum cardiomyopathy. And it's also useful in the prognostication and continuation of how long you want to give the therapy. Echo also in peripartum cardiomyopathy can pick up LV thrombus from anywhere between 10 to 17% is the incidence. So Professor Wander, then Dr. Muruganathan and Ajit, finally your word. How do we set up a protocol? When should we do echoes? Normal pregnancies, pre-eclamptic patients. How can we detect peripartum cardiomyopathy? Professor Dr. Wander, please. Professor.
The pregnancy is, as I said earlier also, pregnancy has some physiological changes which are associated with it. And there is a 40% increase in cardiac output, which continues till 26 to 30 weeks. And at that time, it plateaus actually. So that's the reason we say that it's during the second trimester that the volume overload is maximal. The blood volume increases by about 1 liter to 1.5 liters during pregnancy. The systemic vascular resistance decreases by about 30 to 40%. And the heart rate increases by about 10 to 15 beats per minute. So there are some physiological changes which are happening during pregnancy, which one must keep in mind. On echocardiography in a normal pregnancy, the LV diastolic dimensions are increased, but systolic dimensions are not increased. So any ejection fraction which is normal for a normal person can be abnormal for a pregnant woman because they are expected to have, it's a kind of a hyperkinetic situation. So an ejection fraction of 50% is low for a pregnant woman. Should any normal woman get a echo? No, there is no need for a woman who is normal, who has no cardiac disease. And what are the situations where peripartum cardiomyopathy occurs? As Dr. Uday said, in multiparous women. In Nigerians, as Dr. Bhagwat said, they have incidence of almost 1 in 100, or obese, or elderly women, or multiparous women, or someone who's had actually a peripartum cardiomyopathy in the previous pregnancy. Very important thing is, if someone has a peripartum cardiomyopathy in previous pregnancy, the lady should be told that if she has returned back to normal LV functions, then the chances of recurrence are still about 15 to 30%. But if it has not returned to normal, the LV ejection fraction is 45% or 50%, then her chances of recurrence are much, much higher, and it is an absolute contraindication. So any woman who has had peripartum cardiomyopathy in the previous pregnancy has not returned to normal LV functions on a follow-up. The subsequent pregnancies are contraindicated. On an obstetric point of view, if she still wants to take this risk, then it is actually upon the patient. But it's one of the WHO's modified criteria for contraindications of pregnancies.
Professor Dr. Muruganathan.
Your question was, when do you refer a patient for echo? Do you mean to say all patients should be referred or not?
No, we are trying to say we want to detect peripartum cardiomyopathy a little early, even before they become symptomatic, if they are pre-delivery. So is there a echo protocol? That's the question being asked. Will you do it like at end of 6 months, or what is it?
I'm just deviating from what you asked. We have organized a course for obstetrician, a short course for echo for obstetrician, because every obstetrician are very, very comfortable doing ultrasound. They have the, day in and day out, they are doing ultrasound. If you teach them the basic echo and basic cardiology, they'll be able to do it. So we are organizing a course like that for a short course for obstetrician. And clinically, when the patient comes, and if they have a prominent JVP in sitting posture, thrills, irregular pulse, and there is a diastolic murmur, the systolic murmur intensity is more, the edema is unusual, Those high risk patients, we will refer them for echo. Otherwise, we'll do it, but we must empower the obstetricians to diagnose even mild cardiomyopathy, because they are always doing ultrasound. They'll pick up like anything. So if you teach them a short course, Wanda or Gurunath, 1 month course, just to make them understand what they have to see. They need not diagnose congenital vas valvular disease, etc. They can diagnose cardiomyopathy just by echo. And they have a probe already. Only they need a cardiac probe if they buy, and if they do, it's good. This is my idea, and we are doing a course for all the obstetricians, ECG and echo for them, 1 month course, just for them to empower them to know and diagnose. Even before hysterectomy, they should do this, because they know whether it is risky. Then they'll send it to cardiologist and get the opinion. Thank you.
Okay, thank you. I think we are running short of time. That's what Ketan informed me. And I'm going to make a quick comment and ask Ajit, because we need to wind up. Is bromocriptine, just few quick comments? Bromocriptine, a lactational suppressor, had the problems of
the role of
Ajit.
the role of bromocriptine. As
Yes,
I mentioned,
Ajit.
yeah. Can you hear me?
Yes,
Yeah.
please go ahead.
Yeah. So the role of bromocriptine, as I mentioned, is controversial, and that bromocriptine was actually investigated because it was thought that there is an abnormal metabolism of prolactin that is causing problems in this situation. So there were multiple trials. All the trials are small, obviously because of the less number of patients. But interesting thing is, in quite a few of those trials, a substantial improvement in left ventricular function was seen. Even the number of patients were like 20 or 30 in those clinical trials. So I would say that it is worth giving it a try in these patients of peripartum cardiomyopathy, because sometimes the prognosis is bad and we have very little options.
Right. True.
That's what.
So just one question,
yes,
if you
yes.
mind, Doctor, for the panel. Just I would like to ask you, if the LV function returns to normal, is it the time that we should stop everything, ACE inhibitors, beta blockers? Or we should continue?
It's an important question, not only for pregnancy, but even for patients with, say, other forms of cardiomyopathy, non-pregnancy related cardiomyopathy. Now there is a called recovered LV dysfunction, or
Exactly.
reverse remodeling. And whenever you have that kind of reverse remodeling and recovery of function, it is now there is increasing amount of data which shows that you should not stop the drugs if the patient is getting those drugs. It's very important.
There was a trial by the name Trend HF trial in Lancet published last year, which showed that if you, in a non-pregnant woman, if you cardiomyopathy, if you withdraw, almost 50% of them will return. So that's a very sinister thing to do, actually. Can I just take half a minute on bromocriptine?
Okay, sir.
Yeah. See, bromocriptine, there is a single center study which is positive, which showed some benefit. At present, some people feel that you can use it in those who have very low ejection fractions or women who come with collapse. One caveat is it causes actually a hypercoagulable state. So whenever you use bromocriptine in a peripartum cardiomyopathy, low molecular weight heparin has to be used along with it.
Absolutely.
And at present, there is a large multi-centric trial going on in UK, which will possibly give us the answer in the next couple of years.
Right, sir. We are short of time.
Just one comment, Bhagwat. About 25 years ago, somewhere in 95, growth hormone came for cardiomyopathy. I hope you have some.
Yes, there was a new journal.
Yeah, they used it.
Yeah. Any role for selenium, Ajit? Any role for selenium?
Well, selenium deficiency is known to be associated with peripartum cardiomyopathy, but I have not read anywhere that giving selenium.
Because see, selenium deficiency can cause. So I thought it's logical to add selenium. For their postmortem. I mean,
okay. So I'm going to.
Thyrocare's health checkup. They do estimate selenium, cadmium, arsenic, and all.
Okay, guys. So we are really short of time. Let me summarize in a moment and close this panel. Very good, nice discussion on bromocriptine. 2.5 milligram twice for 2 weeks trials. Then 2.0 milligram once a day for 6 weeks. Please remember, as sir said, always give an anticoagulant because bromocriptine creates a prothrombotic milieu. Thirdly, peripartum, these patients should not be on estrogen contraceptive because you asked obstetrician to come here. That increases the chances of thrombosis. The marine intrauterine device is safe because it's progesterone containing. So the contraception in peripartum cardiomyopathy should have a progesterone based therapy, not a estrogen based therapy. That's a little small message. Professor Wanda told us rebirth is the study of 200 patients that will tell us the answer in future. Thank you very much, Professor Muruganathan, Professor Guruprit sir, Gurunath sir, Dr. Ajit and Dayanand, Ketan. Thank you. We overshot a little time. Apologies. And over to you and Ashish. Thank you.
Thank you so much. It was a fantastic, mind-boggling, and of course, we didn't feel like stopping, but of course, due to the paucity of time, we need to sit. We had a best combination of Pan-India, the stalwart from the north, Dr. Wander sir, and from the south to have Dr. Muruganathan on the same platform, along with our own guy from west, Dr. Gurunath Parale, and moderated by none other than Dr. Uday Jadhav, with the backward of Dr. Obviously, we had Dr. Dayanand Kumla and Ajit Bhagwat. It was a fantastic discussion. Friends, again, let me tell you, all those who have registered, this program is going to be MMC accredited points. So those who have not filled up those datas, please fill in. We have MMC observer with us, Dr. Arvind Gongane, who is present for this observation of this. So please do fill in. And friends, we know as the suggestions which has come obviously may be implemented, like DIPSI, we are going to have a HIPSI with Dr. Muruganathan and Dr. Wander as the committee. I would be definitely ready to join sir for that. Thank you so much. Please be staying. And now we will come to the most crucial part of IAC, and any webinar is not complete without having a ECG quiz. And who better than ECG quiz master, one of my near and dear friend, Dr. Ashish Nabar, who is going to take the quiz today, especially ECGs in pregnancy. I'm sure Dr. Ashish Nabar again does not require any introduction. He is a very renowned cardiac electrophysiologist, arrhythmia associate from Mumbai. He is the visiting cardiac EP at KEM Hospital, Mumbai. He is the honorary treasurer of Indian Society of Electrocardiology, has done his graduation, post-graduation, and the super specialty from KEM Hospital. He is the PhD and fellowship from Academic Hospital, Netherlands. He is a postdoctoral fellow from also the Netherlands. He is also associate professor of cardiology, KEM Hospital, Mumbai. He has been executive committee member of Indian Heart Rhythm Society, and he is going to discuss about various ECGs in pregnancy. Now, friends, I want this is to be a purely interactive session. There are few tips and points which you should be remembering it. When you are going to, when Dr. Ashish will present few ECGs or few questions, afterwards, he will give you a time. So there will be a 30 seconds. He will say your time starts now. That is the time you will start voting. There will be a background music for 30 seconds. And after end of 30 seconds, the voting poll will be reflected on the screen also. Please do vote. I want each one of you to vote. There will not be an individual reply. So your identity will not be revealed. So it will be secret. It will be just what is the percentage flow, what is the audience thinking about the percentage wise, that is going to be reflected. So please participate actively in this. And one more important point is that if you are using a mobile, you will see the questions at the end of the screen. I mean, once you see the question at the end of that, you will see the questions listed over there. And if you are using a laptop or a device, then on the right hand side, the question will be displayed over there. So that is one instruction. Please do vote in. Please do not vote in the comment box, because that is not going to come reflect back. Last time, couple of doctors had voted in the comment box or Q&A. No, please do not vote there. You have you have to reply only in the designated place only. So now it is over to you, Ashish, for Quizmaster show. Now, Ashish, please.
Thanks, Ketan, for devising a very nice and unique program. Uh, I think people have enjoyed the talks as well as the discussion. I would just want that all the faculty, let me request them to stay logged in so that even I can discuss some of the questions with you. Shall I get this on?
Yeah.
No, this is not the one.
That was fine. Perfect.
Yeah. Okay. So when this was designed to be predominantly an ECG quiz, but as I went through the subject, I realized that one needs to provide a clinical background and have clinical discussion also. And ECG is not going to be diagnostic every time. So we will weave the ECG into the clinical and the echo and then do some sort of learning. And as I sat through the last 1.5 hours or so, I realized that there is going to be some kind of a revision of what we have already discussed. Nevertheless, now this diagram is very important. If you look at the causes of maternal mortality, it is very clear that the cardiac disease is the second most common cause of maternal mortality, and therefore it is very nice that we are doing this CME today. Now these are the figures from UK, and not more than 5 years ago. You see that the maternal mortality is just about 2 in 1 lakh patients, so that is pretty low. This may be true in the high income countries, but when it comes to low income countries like us and many more, this maternal mortality is not that less, and therefore heart disease being the second cause and an important cause of maternal mortality, it is very appropriate that we discuss this in depth. And I'm sure I'm joined on this show by physicians as well as some obstetric and gynecological colleagues. So I think it would be a good learning experience for everybody. Now let's start with this question. Which heart disease in pregnancy is most frequently encountered in Indian patients? So I have underlined a particular thing so that you know that we are talking precisely for that point. So the options that you have are atrial fibrillation, aortic stenosis, bicuspid or rheumatic. Option C is rheumatic valvular disease, predominantly involving the mitral valve, or tetralogy of Fallot. So let the polling start. So let me see. Can you see the? I somehow cannot move this diagram. Can you read for me the options?
Sir, can you just stop share and share your screen, sir? Not presentation.
I have to stop share?
Yeah.
Okay. Then can I move the screen?
You have to share a screen.
How can I go to the option?
Share screen and first option, sir.
Okay. So there I am. Thanks. So everybody has voted for the third option, which is...
Sir.
Yeah.
We didn't see your share screen. Just share screen and select first screen.
Yeah, share screen and the first one. Okay, got it. Right? Is that on?
Yes.
Yes, sir.
Okay. So the third option, which is rheumatic valvular heart disease, mitral valve disease seems to be the choice of many. Can I invite some comments from Dr. Bhagwat as to what is his experience of dealing with heart disease in pregnancy? What is the most common or what is the order or what is the frequency of various heart disease that you see?
Well, I don't have the statistics with
Oh,
me,
sure. In general.
But in general, I think you're right. I mean, in India, we see patients, pregnant patients with rheumatic heart disease. If if you compare the 4 diseases, the 4 conditions which you have enumerated,
Yes, yes.
I think the commonest would be rheumatic mitral valve disease,
Right.
rather than tetralogy of Fallot or atrial fibrillation, or what was the fourth?
Correct. This is fourth is aortic stenosis.
Aortic stenosis. I think aortic stenosis would be maybe you will see in Western countries, but not in our country.
Right.
So I think rheumatic heart disease is probably
sure.
that.
Sure. So I think the discussion here was that if you discuss the options, atrial fibrillation is predominantly a disease of the older patients, and the pregnant patients usually tend to be younger. Yes, patients who have valvular heart disease, because of that, they can have more atrial fibrillation. So, but then again, valvular disease is far more common than pure atrial fibrillation per se. Aortic stenosis, yes, that's very true that as a rheumatic aortic stenosis is a much uncommon entity as compared to a mitral valve disease. Bicuspid aortic valve you may see, but developing aortic stenosis may not be as common. And importantly, congenital heart disease is probably more common in the Western world now that they have taken care of rheumatic heart disease. And either de novo congenital heart disease or operated congenital heart disease is going to be more commonly seen in the Western countries. How do I share my original presentation now?
You can stop share.
Okay.
And share screen, and you can see there is a one option screen.
Yeah.
And share it.
Okay. No, again,
now we can see both the same. Now you can just click on a presentation. We can see presentation.
Yeah.
Yes, sir.
Okay. Thanks. So what this is the experience that came about 20 years ago from All India Institute of Medical Sciences, where it's clearly seen that rheumatic heart disease is much more common than congenital heart disease in pregnant patients. And you can clearly see that the mitral valve involvement is again far too common than the aortic valve involvement. Of course, multivalvular lesions are also quite a number 2 to mitral valve disease, but rheumatic heart disease is peculiarly the problem of low income countries, whereas congenital heart disease and many times an operated intracardiac repair done kind of a post-op congenital heart disease is now the predominant problem in the Western countries. At this point in time, I would like to pay my reverences to our Honorary Professor of Medicine at KEM Hospital, Dr. Ajit Cheklikar, who recently expired this year, again out of the damn COVID. And he was the one who many of us in Mumbai remember had a clinic in the Nauroji Maternity Hospital where he saw the pregnant patients. So I really do not know. Dr. Muruganathan was talking of dedicated people. I think he was one such who ran a clinic for pregnant patients. So in addition to his KEM work, he used to run a clinic in the Nauroji Maternity Hospital, and a lot of people in Mumbai would obviously know about it. I do not know of any other place at least in Mumbai, where such a dedicated clinic is on. That's the reason I wish to, remember Dr. Cheklikar. I was also a student of his in my undergraduate and postgraduate days at KU. Well, here is a second question for you. Hemodynamically speaking, which is the most challenging phase of pregnancy in a patient with heart disease? And you can start polling now. I will, just probably will tell you that every phase is challenging. So I have to stop share, right?
No, sir. Just escape.
Okay. And then?
On Chrome.
Okay. So, Dr. Murugnathan, if you are there, would you like to comment? I mean, the obstetrician in a patient with pregnancy and heart disease would probably find every phase challenging. But here we are talking of a hemodynamically, we are speaking, which one is the most challenging phase in the pregnancy? And I think we had some discussion during your moderate discussion with Dr. Jadhav. Would you like to make some comments? The attendees feel that almost 50 to 60% of times it's the labor and delivery that is more challenging. Would you like to offer some comments?
Yeah, I think labor and delivery is challenging because the 50% of the cardiac output or stroke volume increases during the labor, and there is a double-edged weapon. The delivery is a hypercoagulation stage because to avoid blood loss, to bring hemostasis, hypercoagulant stage. Suppose there is any problem, then especially the delivery phase, you'll have to be very careful about adding the solutions, adding the IV fluids, and then followed by there will be a PPH, there will be so many complications. So the hemodynamic changes are more. And if the patient has got physiological anemia, there is no problem. If there is no physiological anemia, the viscosity will be more, and then there will be a problem. If the hemoglobin is more than 14, the PCV is more than 65, again it's a problem. So the challenge is only during the labor, the third phase.
Right. So are you seeing this screen of mine, Janish? Are you seeing the presentation?
Yes, yes.
Yes, sir, we could. Thank you.
Right. So, it's very correct that every phase of pregnancy is going to be challenging in some way when the heart disease is significant. The reasons are different. When one discusses labor and delivery, one is talking of a situation where the uterus contracts and a lot of blood volume goes back into the circulation, and that obviously imposes a problem. But if you look at this chart, this is very informative, that in the second trimester onwards, you can see that the cardiac output continuously rises. Yeah. And that imposes a load on a patient with heart disease, particularly when it is of severe nature. In the initial part, the rise in cardiac output is mainly related to the stroke volume. Whereas in the third trimester, it is mainly the heart rate that builds up the cardiac output. So whatever be the underlying mechanism, the cardiac output tends to go almost 50% high from the second trimester of pregnancy, and this has to be accommodated in the diseased heart or circulation. So that obviously creates its complications. The other thing is that there is a drop in hemoglobin, which is very well known to the gynecologist as the physiological anemia of pregnancy. And that obviously is a stress when you have a significant heart disease. Now, I would like that you concentrate on this line, which shows that the peripheral vascular resistance tends to fall during the pregnancy. Now, my next question is very much based on this aspect, and I would and attendees would do good to remember this point. So the question that I have for you now is, which is relatively easily manageable heart disease in pregnancy? And by relatively easily, I mean that you can manage with medical treatment. You do not require a particular intervention through the pregnancy. There is no much clinical worsening, and generally the fetal outcome is good. So that is my definition of relatively easy. So A is severe aortic stenosis, B is severe mitral stenosis, C is severe mitral regurgitation, and D is Eisenmenger syndrome. So the count can start now, and you could vote. So we have the following response. Only almost 70% have said that it is the severe mitral regurgitation that they would be easily able to manage. I'm sure Dr. Parle is around, and Dr. Parle, can I invite your comment on what is the difficulty? Why is mitral regurgitation, as people think, more easily manageable? And do you agree that the other conditions are going to create more difficulty to manage them manage the pregnant mother? Dr. Parle, are you around?
Yeah.
So please, if you can say something.
Yeah, mitral regurgitation is the best condition. I agree is to be able to be managed during pregnancy because peripheral vascular resistance decreases during pregnancy, and as such, the severity of mitral regurgitation might decrease during pregnancy. Severe aortic stenosis is a critical cardiac output condition, fixed cardiac output condition, and is definitely very difficult to manage. Difficult in the manager sense because managing severe aortic stenosis will involve, you cannot give high dose of diuretics because that can cause hypotension. You cannot give fluids that can cause pulmonary edema. And the only treatment will be a mechanical treatment, aortic valve replacement, which will be until open heart surgery. As against this severe mitral stenosis, if you are not able to manage with medicines, maybe you can undertake balloon valvotomy, which is relatively low risk procedure. But as against this, severe mitral regurgitation can be managed purely medically. And I think that is the best condition which we would like a patient to have if given a choice.
Right. So, if there are certain dictums that can be given, the obstructive lesions are going to be very difficult to manage in pregnancy because of the raised cardiac output, and these patients are going to have worsening of their NYHA class, maybe land up in pulmonary edema, maybe land up in heart failure. So stenotic lesions are going to be difficult, and as Dr. Parade rightly said, the regurgitant lesions are going to be easy to manage if the LV dysfunction has not set in. And there was some discussion about LV dysfunction, as 50 may be okay in a normal person, but 50 in pregnancy may be low. So if your regurgitant lesions are generally with good LV function, they are going to be not too difficult to manage, and you can bring these patients to term with medical treatment. But stenotic lesions, and remember, Eisenmenger is also a fixed output state with a severe pH, and as good as the other two lesions that I mentioned here. So stenotic lesions are going to be difficult. You might have to intervene. You might not have a good fetal outcome if surgery is required and things like that. We will discuss that further. So it's very true that, so there are certain lesions that are low risk. So these patients may come to notice if they were only previously known to have heart disease. They may not necessarily be easily picked up by physical signs. So these are small shunts, small regurgitations, small mild stenotic lesions, mitral valve prolapse or bicuspid aortic valve without a lesion. So these are some of the lesions which may be called heart disease technically, but they may come to the notice of obstetricians because the patient has been diagnosed previously and not particularly because of worsening of the symptom class. Whereas some lesions are such that they are intermediate risk. They would definitely come to notice if they have been previously diagnosed, but certainly they would have some worsening of symptoms and some physical signs to be picked up, and they could create definitely some problem during the pregnancy requiring more aggressive treatment. But it may not be that these patients would be advised absolutely against pregnancy. Sometimes you may correct the lesion before the lady gets pregnant, or at times, as Dr. Parale said, a balloon mitral valvotomy may be offered for mitral stenosis during the pregnancy. And we had also a lot of discussion on if somebody has a mechanical prosthetic valve, you would be having to manage the anticoagulation pretty religiously through the pregnancy. So these may not be absolutely contraindicated for pregnancy, but you will have to, in the pre-ANC discussion, alert the patient as to that these pregnancies could be eventful and they would require more closer follow-up. So these are classified as intermediate risk. Now, this is a very interesting demographics of heart disease in pregnancy. Yes, usually they are younger patients. So, but nowadays we get elder mothers, and just like we discussed hypertension, that could be a problem. Many times they are diagnosed for the first time during pregnancy. If you look here, almost 60% of the patients are diagnosed during their first pregnancy. So they were not known with a heart disease, and when they get pregnant, they are suddenly found to have a heart disease. Now, this is a little malady. Many times they are diagnosed after 20 weeks, which rules out the possibility of doing a medical termination of pregnancy. So that's a little malady, and you have to form a team of a physician, cardiologist, obstetrician, pediatrician eventually, and then try and make it a safe pregnancy, which can be challenged in difficult lesions. This says that many of the heart diseases can be missed through the pregnancy because many times the symptoms are mild. A lot of them have mild symptoms and you could miss it. They could be on a number of so-called cardiac medications, then that is how they may come to the notice of the gynecologist, who may be alerted for the first time that these may be heart patients, and then they should have a closer consultation with the physician or the cardiologist. And cyanosis obviously tells you that this may be a cyanotic congenital heart disease. So the demographics is pretty interesting. Now here is my fourth question to you. Why is a new diagnosis of heart disease difficult in a pregnant patient? Once again, we did discuss a couple of these things through the talks, and I would request Dr. Kumla's impressions on this. The options that you have are, they are difficult to diagnose because the symptoms are mild and they are not investigated. Or physical science and ECG, what is the most common thing available with a physician? I mean, today every cardiologist has an echo machine next to him and can always extend his examination further. But a physician has to deal primarily with physical science, history, and ECG. So they they are not so diagnostic. The third is, many times the lady registers late and has no cardiac medications prescribed, so the obstetrician has no clue that they have a heart disease. Or all of these could be happening at different times, and therefore the diagnosing of heart disease in pregnancy gets a little difficult. Your voting can start now.
Ashish, just one point. Don't display the answer form, because people get biased by they start seeing the response.
Oh, okay, fine,
just
sure.
open the response only after the music is over.
Okay, got it. So I think this seminar has definitely done good to the learning. Almost more than 85% of the people rightly thought that at different times all of these above could be responsible. Dr. Kumla, if you are around, can you please elaborate on what is your experience? Why the conditions sometimes get diagnosed late in pregnancy and are not diagnosed very soon? Do you have some examples of such situations? Dr. Kumla, are you there? Let me ask Dr. Uday Jadhav. Uday, can you offer some comments on why pregnancy in heart disease tends to be a little underdiagnosed? I think Uday is... Dr. Wander, are you there? Okay, let me take this further to other. Yeah, sorry.
Ashish, I can take this if you want.
Sure, please.
Because we discussed it during my...
Dr. Wander has come. Dr. Wander has come.
Okay, let Dr. Wander take it. Then.
Sure. Okay.
Yeah, so this is a good question actually, because it just does highlight for obstetricians, I think, who are attending this meeting, that a high index of suspicion for cardiac disorders is very important, because some of these symptoms are overlapping, because women will be having a high output state, and some of there is a gravid uterus which is actually into the abdomen, and there are some symptoms because of that. ECG can have slight some tachycardia, about 10 to 12 beats per minute, some slight 15 to 20 degree left axis deviation, non-specific T wave abnormalities can be there. So a high index of suspicion, good clinical examination of the cardiovascular system, because we know mitral stenosis itself, although it's going to speak up for itself by causing more breathlessness, maybe hemoptysis sometimes to these people. But as you so nicely actually highlighted the dictum, which I can only re-emphasize, that regurgitant lesions and left to right shunts, whether it is AST, VST, PDA, or MR, AR, they tend to actually do very good in pregnancy because of the decrease in systemic vascular resistance. And because of that, the shunt or the regurgitation decreases. Right. But the problem is with the stenotic lesions, the mitral stenosis, coarctation, aortic stenosis, and of course, the absolute contraindications to pregnancy, that is severe symptomatic aortic stenosis, Eisenmenger's, primary pulmonary hypertension, ejection fraction less than 30%. So,
so very true. I mean, this actually tabulates what Dr. Wander has said, that if you look at the two tables, one is normal and one is abnormal, and you can see that there is such an overlap. I mean, what is breathlessness on exertion and what is extreme breathlessness? The good clinician in you should be able to, take a good history. Mild peripheral edema, you see in pregnant ladies, you have to pick up a more pathological kind of pulmonary edema. There is a heart rate rise, there are hemic murmurs. So all that can create a little difficulty before an obstetrician really wants to refer the patient to a physician or a cardiologist to resolve whether it is just a normal symptom or whether it's anemia of pregnancy that is playing a role or whether there is a real heart disease. So these various factors sometimes create a certain delay. Busy practice may be another thing, practical thing, but then these are some of the reasons why the patients are referred with a little delay. Now, here is one important question is that I want to ask you is, you are a very astute clinician. You do a good history taking, you record a ECG, and still there is a chance that you may miss the heart disease. And which of these four options you think that you will miss a heart disease very easily? In other words, you will require an echo to complete your possibility of diagnosing a heart disease in a pregnant lady. So think carefully. You only have a possibility to take a good clinical examination and record a ECG. And I'm asking you, which one will you certainly miss? So your time starts now. Is it the bioprosthetic mitral valve, patient who has had that, systolic dysfunction, aortic root dilatation, or obstructive hypertrophic cardiomyopathy? And I expect a little spread out response in this depending on your experiences. So let's see.
8, 7, 6, 5, 4, 3, 2, 1.
Right. So I will be probably asking at least two people, and I expect a lot of difference in opinions, and it would be definitely some learning. And rightly so, you can see the spread in the answers, 27%, 44%. People feel that aortic root dilatation is obviously not easy to diagnose with the given examination at your hand. LV systolic dysfunction and HCM to some people is difficult. Now, let me ask Dr. Bhagwat to debate on this. What in his view would be the difficulty in making a diagnosis with these four issues?
Yeah, this is a tough one. Needs little discussion. Let's. Your question is clinical exam and ECG alone.
That's all you have in hand, and you are likely to miss.
Only two modalities you have.
Yes.
And which one of the four you are most likely to miss? That's your question.
Yes.
Now,
Dr. Bhagwat, this is like taking a MLA again.
yeah, that's true. So, bioprosthetic mitral valve replacement is, if you have you.
So what I want to say, Dr. Bhagwat, here, that the valve clicks may not be easily, and so can you miss it?
Yeah, you can miss, but you will see the scar on the patient.
Exactly.
You will have the history. So
Yes.
you know that something has been done to patient's heart. So,
yes, absolutely.
That may be an important clue. Bioprosthetic mitral valve patient may not have issues with anticoagulation, so that may not be important. But a scar and history of surgery
absolutely
will help. Now, I think the question, the close tie-up will be between B and C. LV systolic dysfunction and
so you take the D first and then come.
Yeah, I will take D first, because hypertrophic cardiomyopathy, if all said and done, the signs of hypertrophic cardiomyopathy would worsen during pregnancy, because the peripheral vascular resistance will go down and cardiac output in stroke volume will increase. So if there was a soft murmur before, the murmur will increase, and it's very unlikely for somebody to have a completely normal ECG in presence of hypertrophic.
That's right.
So those two are important things.
Right.
As far as LV systolic dysfunction and aortic root dilatation is concerned, you can miss both with ECG and clinical examination. But again, if you want to bank on ECG, if you have LV systolic dysfunction, there is a chance that you will see some some ECG changes with LV systolic dysfunction, but they could be passed off as normal during pregnancy.
Right.
So, it's very tough to differentiate between B.
So, Dr. Bhagwat, what kind of a patient has aortic root dilatation?
Well, aortic root dilatation, you're talking about aortic root dilatation. A patient may have an underlying valvular disease, or a patient with cystic medial necrosis, or patient who has got some kind of Marfan syndrome, connective tissue disorder. These are the patients who can have aortic root dilatation. And
of significance,
of significance. Now, pregnancy is supposed to, hasten the process of aortic root dilatation, or say kind of aortic dissection or coronary dissection. These are the syndromes which you commonly see during pregnancy. Right. So, suspicion of these things is also important, but you can certainly miss aortic root dilatation solely based on clinical examination ECG. So if you're suspecting it in a patient with connective tissue disorder, or a patient with aortic valve disease, or a patient who has Marfan syndrome, then you have to do some imaging to diagnose it. So that's what I would.
No, I'm sure. I mean, this is as well discussed as it can be, and very realistically. My point when framing the question was obviously that between B and C, how to make a choice. And the thoughts in my mind was that a patient with aortic root dilatation usually has a bicuspid aortic valve with aortic stenosis, or he has a Marfan syndrome. And while bicuspid aortic valve with aortic stenosis can be picked up by a murmur, a Marfan syndrome obviously has a lot of other physical signs, the tallness and things like that. So, you would not diagnose aortic root dilatation, but you would suspect if you had these things. Whereas a person with LV systolic dysfunction might really go unnoticed completely till you thought that the dyspnea was significant and you ordered for an echo when the ECG was pretty equivocal. So that was little thinking when I had wanted this question to be discussed. Okay, let's move on. So basically what I want to bring home to a physician and an obstetrician is that history, examination and ECG is obviously the first thing to do. But an echo is required in most of the occasions to check the ventricular function and the valve function before you diagnose a significant heart disease. And we did have some discussion in earlier where the discussion was that should everybody get an echo, or at what point would you do the echo? I think the NYHA class would be the one that would guide an obstetrician or a physician to press for an echo. And I don't think getting an echo or doing an echo is that difficult in the present days. Exercise test can be done for functional assessment, but not that you have to do it many a times. And some things about anticoagulation we will discuss later. So here is what Dr. Bhagwat said, and this is very important, is that it's only imaging that can measure for you the aortic dilatation. And as he rightly said, that there is a tendency for the aorta to dilate sometimes rapidly during pregnancy and lead to aortic dissection, which can be fatal when it is at certain places. I'll not go into too much of details, but if it is less than 40, these people can usually be followed up on a certain lower frequency. But if it is above 40, they need to be followed up much more frequently. And if it's more than 45, these people have more chance of landing with a dissection. And therefore, many a times, if it is diagnosed in the pre-pregnancy time, they may be even required to be advised a surgery, an aortic root replacement surgery, before they can be allowed to get pregnant. So aortopathy is a pretty serious concern. It doesn't happen, or you don't see so many patients as a public health problem. But when you see a Marfan's or aortic stenosis, you have to see that your echocardiogram has reported on the possibility of an aortopathy. Here is one more question for you. Which condition is prone to have the worst maternal outcome? LV dysfunction with advanced level of symptoms. So it's the worst maternal outcome. Do what you may. That is the question. Severe mitral stenosis with already one admission for pulmonary edema. Somebody has an operated tetralogy of fallow and no significant residual lesions, which means that there is no severe PR, pulmonary regurgitation, or RV dysfunction, or an arrhythmic event. Or is it a patient who has a mitral valve replacement with a bileaflet mechanical valve in situ? You can start polling now. Once again, as a physician or an obstetrician, you might be feeling intimidated with all these conditions, and truly so. But let us see what the discussion is here. So if you are to look at the, if you are to look at the answers that have been offered, let's see, one second. So people believe, or rather they believe that a mitral stenosis would have a worst outcome, whereas their second choice is for LV dysfunction with advanced symptoms. Now let me discuss this with you, and then we can have some discussion with the faculty. Now, see, tetralogy of fallow, which is operated by itself, a tetralogy of fallow is an important congenital heart disease. But once you repair that and there is no important residual lesion, like they can have a pulmonary regurgitation, a RV dysfunction, or a ventricular arrhythmia. If the patient has nothing, as has been in a regular follow-up, you do not necessarily advise them against pregnancy, and they can certainly be managed well in the absence of residual lesions. So it is pretty conditional that I have put it here. A severe PR and RV dysfunction patient would obviously bring its own problems. Mitral valve replacement, yes, it is. It means that the heart disease has cardiac surgery has happened, and a valve replacement, especially it's mechanical, you will have to deal with anticoagulation problems. That is a separate discussion we'll have. But what I wanted to discuss here is amongst the different valves, mechanical valves that are used. So one is the cage ball valve, the Star Edwards prosthesis. The other is the tilting disc valve, which is the single disc, the Medtronic Hall valve. And there is the St. Jude medical bileaflet valve. Now, amongst these mechanical valves, the bileaflet mechanical valve is amongst the safest. And therefore, if you manage your anticoagulation well, despite this valve being in mitral position, you probably can pull off the pregnancy still reasonably well. Not that it is not going to raise any challenging issues, certainly possible, but that's the argument there. Whereas mitral stenosis, the availability of balloon mitral valvotomy has made a huge difference, and I really call it a godly procedure. Working in KEM, we have done a lot of these procedures. A lot of patients with mitral stenosis and in pregnancy have been referred, where we have done elective balloon mitrals when the patient's symptom class is not high, waited for them to be in second trimester and then done. Whereas some have landed up in pulmonary edema and there was a pressing need to do a balloon mitral valvotomy, and many of the faculty who must have provided similar treatment to the pregnant ladies with mitral stenosis. I think the most difficult situation is this, where you have a LV dysfunction and during the pregnancy, the NYHA class has worsened significantly to NYHA class 3 or 4 or lands up in pulmonary edema. And some of the points that we discussed were that you cannot use all the medications that you can use in a heart failure patient in normal course. So you cannot use your ACE inhibitors, you cannot use your ARBs, you may not be able to use digoxin so easily. So except maybe beta blockers, you cannot use calcium channel blocks. Obviously, you don't use here. But ACE and ARBs, which is the main crux of the treatment in the LV dysfunction, you are not able to use in these patients. So that does create a lot of problems. The new drug that the ARNIs, obviously, they also can't be used. So your hands are pretty tied down to your isosorbide dinitrate hydrolazine combination and diuretics. So you could have you could feel a little difficulties, or you could have a lot of difficulties when you're managing advanced heart failure in a patient who has who is in an advanced stage of pregnancy also, and you would have to take a call whether it is safe to allow a vaginal delivery in this patient, because in labor, if she lands up in pulmonary edema, you have more difficulties. So whether you should do a cesarean section and do a planned delivery in these patients. So there are a lot of questions that you would need to answer along with the obstetrician as to how to give a safe maternal and fetal outcome. Dr. Wander, would you like to discuss this further? Or Dr. Jadhav, are you there to discuss this further? Anybody? I mean, Dr. Ketan.
Yeah, Ashish, again,
yeah, Dr.
There
Bhagwat.
is nobody I can.
Sure.
So just a few comments.
Yeah.
This is again an interesting question.
Yeah.
I think C and D are pretty self-explanatory. We are assuming that the mitral valve mechanical valve function is okay.
Yes.
It is not a thrombosed valve. We're assuming that. So C and D are out of the equation. So we have to differentiate between 1 and 2. And
Yes.
your question is, which condition is prone to have the worst maternal outcome?
Yeah.
Now, as far as the short-term maternal outcome is concerned, you may be able to handle both, with aggressive diuresis and managing the patient,
Yes.
or doing, emergency BMV in a patient with mitral stenosis. But you have correctly said that, maternal outcome is short-term as well as long-term. Long-term maternal outcome is certainly bad with A, because B, you can certainly handle it with, subsequent mitral valve treatment.
Yes.
But the LV dysfunction with class 3, class 4 symptom, I would first try to see if our obstetrician is ready to terminate the pregnancy in whatever way he can, because that's something which is
right. So in first trimester, you have that. Yeah.
Yeah, but you don't have that option in every situation.
Yes.
So you have correctly said that the situation is so bad that you cannot terminate the pregnancy, you cannot use the drugs which you want,
yeah,
and you don't have any surgical options either.
That's right.
So it's kind of you are stuck from all the sides, and that's why A is something which is most ominous.
Right. So these patients may need to be admitted, given bed rest, monitored on a daily basis if they are in such a high symptom class. And you may have to think of doing a cesarean, a planned delivery, not daring to allow them to go into a labor and land up in pulmonary edema. So, the ideal world is where you would not allow pregnancy, as you said, in a patient who is in NYHA class 3 or 4 or severe pulmonary hypertension or a very large aortic root or severe aortic stenosis. You might, if possible, in situations like aortic stenosis, want to treat that lesion before they get pregnant in ideal world. But the real world is that you land up these patients with severe heart disease, you see them getting pregnant in an advanced stage of pregnancy. You don't have the option of offering an MTP, and you have to manage them. And therefore, it is this multidisciplinary team deciding about vaginal versus planned cesarean section, a number of things that you have to do, and post-op monitoring in intensive care. So the real world is always a little different and difficult, and you may have to join hands, the obstetrician, the perinatologist, the physician, the cardiologist, and try and make it a safe journey for the pregnant lady. So this is the case that I want to discuss with the attendees. Now, this is the first case. In an ANC clinic, you see a lady with 22 weeks of pregnancy gestation. She's in NYHA class 3. And you can hear the obstetrician hears a mid-diastolic murmur with a pericyclic accentuation in the mitral area. And clearly there is a mitral stenosis on the echo, almost 0.5 centimeters square. We used to call that, at least colloquially, as a pinpoint mitral stenosis. You can see the turbulence there. The question is the following. If you got a chance to look at the ECG, which according to you, which of the following ECGs suggests that it's a high risk patient with severe mitral stenosis? Every mitral stenosis is a high risk, obviously, but which amongst this, in your opinion, is more difficult to manage, more high risk patient, which means more chance of pulmonary edema or more chance of requiring a balloon mitral valvotomy on an emergency or a planned basis? So look carefully at the ECGs and you can answer, you can pick up your choice. So let the voting start now.
Ten, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Okay, I switch screens and let us see what the audience has to offer. So, you know, the first ECG, and we'll discuss that, but here the ECG 3, the third ECG seems to have caught the imagination of most of them as being the most difficult to manage. And I do agree with that, and I'll tell you why. If you look at the first ECG, you probably wouldn't even want to suspect a mitral stenosis, but it is possible to get a such ECG where you don't see any right axis, you don't see very diagnostic left atrial enlargement, and it's only the murmur and the symptoms and the echo that made you diagnose. So, you know, this ECG is possible in mitral stenosis. This patient may not be having a severe PH. But if you look at this ECG, the rhythm is sinus, there is a left atrial enlargement, there is a prominent R in V1, and there is a right axis. So this patient obviously has a left atrial enlargement with right ventricular pressure overload, or a severe PH, and therefore once you know that this patient has mitral stenosis, this is a pinpoint mitral stenosis with a severe PH. And in addition to this, this third patient obviously has the same features of a little R in V1, a right axis, so it is a similar kind of a patient, but this patient also has atrial fibrillation. So again, here you have to not only manage the mitral stenosis if required with the urgent or a planned balloon mitral valvotomy, but you will also have to take care of anticoagulation, which again is a certain problem in pregnancy, and different anticoagulation agents bring in their own problems. So that's why the highest risk in a mitral stenosis patient would be probably associated with a patient who has this ECG. So I'm sure that you will not be wanting to take the D option anymore. Let's move on. Now, which mitral stenosis are difficult to manage? It is mainly those who are pinpoint, because they're certainly going to land up in pulmonary edema. Patients are already in higher NYHA functional class. It's better that you do a planned BMV than having to do an emergency balloon mitral valvotomy. Patients who have already had a risk of pulmonary edema are going to be high risk. Severe PH are going to be high risk. Atrial fibrillation, I said, will need additional anticoagulation. And those who have calcific valve will be again a difficult patient for balloon mitral valvotomy, and doing a cardiac surgery during pregnancy is associated with a very high fetal wastage, almost more than 25%. So these are difficult to manage mitral stenosis. I did say that the balloon mitral valvotomy is a really godly procedure. I mean, you relieve these patients of the mitral valve and get them through the pregnancy. As a cardiologist, I have felt happy many a times. The question that I want to ask you is, where is a balloon mitral valvotomy contraindicated in a patient with severe mitral stenosis and pregnancy, where you want to do it, but you cannot make that decision? So your options are the following: a calcific valve, a patient who has a thrombus in the LA, one who has a coexisting moderate MR, or any one of these would make you worry. So let your answering start right away. again, I would request Dr. Bhagwat to help us here as to how does one decide which patient is suitable for doing balloon mitral valvotomy. Most of 50% have felt that any one of these would make planning a BMV difficult in a pregnant lady. Would you have some
audience
comments?
You can hear me, right?
Yeah, I can. We can.
Yeah. So the audience is right in saying that all these three, calcific valve, left atrial thrombus, and coexisting MR, would make BMV a difficult proposition. The only thing is, it all depends on, let's take, say, for example, left atrial thrombus. Now, if the thrombus is in the cavity,
yes,
it really poses a threat for embolization. But if it's in the appendage, there are a number of situations where number of case reports, and in our own experience we have done patients who have got only left atrial thrombus, but nothing in the appendage thrombus, but nothing in the cavity. So that's a relative contraindication. But if you see a sizable thrombus in the cavity, it's better to avoid it for the risk of embolization. The third thing is coexisting moderate MR. Now this is again a tricky situation. With mild trivial MR, you can always go ahead and do it. But moderate, I would certainly discuss with the patient an option of mitral replacement to begin with, and tell him that it's possible that doing a mitral stenosis, BMV in this situation can land you in trouble, and you will require an emergency surgery. But again, sometimes assessment of grade 2 versus grade 3 MR may be a little difficult, and people have, if it's a fix, something like sometimes if you open the valve, the mitral MR need not necessarily worsen, and it will give some additional asymptomatic years to the patients. So that's again not an absolute contraindication, but I would certainly discuss it with the patient before doing it. And calcific valve, of course, the results are pretty bad, and I would refrain from doing it.
Correct. So the sentiment that you are trying to convey here, if I understand, is that you would try your best to see if a balloon mitral valvotomy is possible in a patient with MS who's landed in pulmonary edema or has had a pulmonary edema prior or has a higher symptom class. And because we understand that offering an open heart surgery during a pregnancy would entail a big percentage of fetal wastage, which again is somewhat not acceptable. Of course, a maternal life probably has a priority, but you wouldn't also want to have a high fetal wastage.
True.
Okay, let's move on to the second case. So this is a lady with 5 months of gestation. She had an NYHA class 2 with a reasonably good LVF reported previously. That is what the obstetrician discovered by going through the past notes. Probably not more was known. And during this pregnancy, now at say 5 months, she had worsening of symptom class 2, class 3. And that's how the obstetrician decided to, auscultate a little better. And there are multiple murmurs heard. So the first step was to increase the diuretic dose and then take a reference. Now in the current COVID era, I'll show you the ECG again. As a cardiologist, you are requested a teleconsultation, Dr. Bhagwat, and by the obstetrician. He's somewhere remote he's not in Aurangabad, somewhere in a remote place, and he wants to take your best opinion as a clinician. So this is an obstetrician. He is not able to necessarily exactly tell you at the apex it's systolic or diastolic and things like that, but he hears multiple murmurs, he says. So I'll let you have a look at the ECG again, and maybe a little bit suggestion from my end. There is atrial fibrillation, there is deep S in V6, and there are also LV forces. So that's what I gathered from the ECG, and you heard that the patient has a worsening of symptom class and multiple murmurs, and these are your options. So is it aortic regurgitation with LV dysfunction that is troubling, or is it the combined lesion of severe AR and MR or is it a mixed aortic and mitral valve disease with one of them having a stenotic lesion, or is it dilated cardiomyopathy? So this is a remote consultation, and what is your best suspicion in this case? So let's first vote and then discuss a bit. The voting can start right away. This question is probably more intended for the physician as to how they can look at the ECG and try and guess from the history provided. Many of you must be doing teleconsultations and have to offer some directions to the referring obstetrician.
3, 2, 1.
So if I were to look at the responses first, let's see. The responses are that they think that it is a mixed aortic and mitral valve disease, and probably one of the valve has a stenotic lesion which has worsened. Dr. Bhagwat, your discussion. Dr. Bhagwat, are you there? Yeah, sure. So let me take this and move on. So the general understanding is that patients who have regurgitant lesions might not do badly during pregnancy, even if the lesions are severe, as I have put it in the second option. So maybe they wouldn't worsen really unless a patient with regurgitation has a LV dysfunction. So this patient can definitely worsen. But what I have tried to point out in the ECG is that there is a RV enlargement as well as there is atrial fibrillation. So a patient with aortic regurgitation usually does not land up into a situation of a left atrial enlargement and a pulmonary hypertension, unless it's a very advanced disease. So for me, the call is that this patient already had a mixed mitral and aortic valve disease, as a result of which he was relatively balanced in symptoms with NYHA class 2. And the moment but if one of that lesion is a stenotic, so even if he has aortic stenosis and AR with a mitral regurgitation, or a mitral stenosis and AMR with aortic regurgitation, this patient is more likely to worsen in the presence of a stenotic lesion. And therefore, I'm quite on with the options, the answers provided by the audience, that this is probably a mixed disease with one of the valve being stenotic, and that's how it turned out to be. There was a mitral stenosis, there was a aortic stenosis with high velocities across the aortic valve, and there was aortic regurgitation. So to sum up, a mitral stenosis patient does need a balloon mitral valvotomy if the symptom class is high or the pulmonary pressure is high. Aortic stenosis patient with severe AS should be advised a correction of the lesion before they get pregnant. If once they get pregnant, this is very uncommon situation, but they can be offered a balloon aortic valvotomy, especially if it's a congenital bicuspid aortic valve. Usually the mitral regurg and the aortic regurg would do well and would be able to undergo vaginal delivery. The stenotic lesions might be better offered a cesarean delivery, and Epstein's, which is a tricuspid valve regurgitation, would once again in most situations have a pretty uneventful course and a vaginal delivery. There is difficulty to offering surgery in some of these lesions during the pregnancy, because one, cardiac surgery access is not so much except in our big cities. Valve repair again is a good option, but the expertise for valve repair is not such widely available. Bioprosthetic valve, one may intuitively think is a good thing to do in a person who wants to get pregnant again, but the risk of degeneration of the valve is very high. Mechanical prosthesis is therefore offered most of the times, and you have to manage these pregnancies with good care of anticoagulation, worried about valve thrombosis. And if you have to compulsorily go in for a cardiac surgery to save the mother, then there is a very high chance of fetal ST. So all these things have to be in mind in the team's discussion when one has a patient with a valvular disease. Now here is your 10th question: which prosthetic valve is least likely to thrombose during pregnancy? Again, this is very important. You have 4 options: a bioprosthetic valve of a particular type in mitral position, a Medtronic Hall valve in mitral position, a St. Jude bileaflet mitral valve with atrial fibrillation, or a Starr Edwards, that is a cage ball valve in aortic position. So let's have your answers. Your voting can start. I think the physicians would do good to answer this correctly, because some knowledge of the valves would help you. So let's see first the options that have been answered, and
Ashish, we'll have to keep this as a last question.
Sure,
Since
sure.
Yeah, once we finish.
Yeah. So this is the answers that we have. Many people think that the bileaflet mitral valve is probably good, and the second option is a bioprosthetic valve. Now let's move a little bit to the discussion as to, so the prosthetic valve, which is good. Now naturally a if you have a patient who is pregnant with a prosthetic valve, the chances of thrombosing is least with the bioprosthetic valve. That is a straight away a given thing. And especially if the patient is in sinus rhythm, even if it's in mitral position, the chance that it thromboses is less. Any of the mechanical valves can thrombose if the anticoagulation is not taken care of. Here you have the Medtronic Hall valve, which is a tilting disc valve, so that has more risk of thrombosis, although being in sinus rhythm is a good thing. Here you have a St. Jude medical bileaflet valve, which is the less risk of thrombosis, but this patient is in atrial fibrillation, so increases the chance of thrombosis. And this Starr Edwards is a cage wall valve, which although in aortic position, the chance of thrombosis is less, but this is a little bulkier valve. So all these three have a little higher risk of thrombosis, being mechanical valves, as well as with some of the other things that are discussed. A bioprosthetic valve probably has the least chance. So if I were to quickly finish on this, every antithrombotic agent has some problem. A warfarin has a risk of embryopathy. Low molecular weight heparin is not completely proven to be a great thing to do throughout the pregnancy. There is a risk of thromboembolism or a risk of valve thrombosis. You have to monitor the anti-10A levels. That was something that was discussed by Dr. Muruganathan. Ultra-fractionated heparin may be a good thing to do with monitoring, but again, it's very tedious to give intravenous heparin on an ambulatory basis. And the newer drugs, NOACs, are not approved for use with the valvular lesions. So once again, they are not available to us for use during pregnancy. I think as some of these things have been discussed previously, in the 6th to 12th week, it's good to be off warfarin to avoid an embryopathy. From 13th to 35th week, one can use the coumarin derivatives. 36th week, you stop the warfarin and use subcutaneous LMWH or ultrafractionated heparin. And again, during the labor or just prior to labor, you have to stop heparin to have less bleeding during the delivery. So some of these things have been discussed. I think they have provided some revision to you. And I think I'll stop here, not before thanking Dr. Ketan Mehta. This is the last in the series of our common cardiology care session. We must also thank Sidus, but importantly, Ketan, having taken up the mantle of the secretary, has really brought in some new topics which are extremely relevant from a physician's perspective, and have probably brought value to all the audience who is attending. I thank you very much for your patient listening. Thanks. Ketan, over to you.
Thank you. Yeah, thank you, Ashish. Can you stop sharing your slide?
Yeah.
So it was a fantastic session, and probably everyone were glued to this device, and that was a fantastic quiz, not only from the physician's viewpoint, but also from the obstetrician's viewpoint. And we had this marvelous session. Probably just time was just flowing like anything. Friends, finally we have come to the end for today's session, and we have seen the stalwarts galaxy of speakers from all part of the country who have discussed today's important talk about the cardiology in pregnancy, and we are thankful to all of them. Also, I would like to remind you that, as I already mentioned earlier, that this is going to be an accredited program, and all 4 modules we had in C4, that is Common Cardiology Care for Clinicians, which was an accredited program. So all of you who have not yet registered can still do the registration, and you will be entitled for that certificate. Plus, all those who have attended all 4 modules will be getting a certificate for completion of this C4 module, that is Common Cardiology Care for Clinicians. This entire 4 modules was prepared by Indian Society of Electrocardiology with the help of our senior mentor and our the chief patron come advisor, Dr. S.B. Gupta, my colleague, Dr. Ashish Nabar, treasurer, our president, Dr. Ajit Bhagwat, and myself, which we have prepared it and which has really given rise to this fantastic outcome. Now, I cannot just forget, and but the most important part about carrying out this entire activity, it was the help unrestricted educational grant which has come from Zydus Cadila. The medical advisor, Dr. Samir Muchala, has helped us tremendously, and the entire team of Zydus Cadila, including Mr. Jainesh Patel, Mr. Gautam Ghosh, Mr. Vishwanath Kamath, of course, Mr. Anil Matai, and Pankaj Bhai Patel and Sharvil Bhai Patel, who are now in forefront for the COVID vaccine preparations. We cannot forget their help. And of course, today being such a crucial day, so many webinars, and a crucial second one-day match between India Australia, where Australia has given a mammoth target of 390 runs to India to win, to chase the score, which is at the rate of 7.8. Still, you all people have been stick to us. That is, we are so much thankful to you. And I would hand over the charge to Dr. Samir Muchala. He's the Chief Medical Advisor from Zydus Cadila to give the final vote of thanks. Thank you so much.
Thank you, Dr. Ketan Mehta, for your kind words. I think we had great deliberations today on cardiology and pregnancy. Powerful orations by Dr. Dayanand Kumla with respect to PI, Dr. Ajit Bhagwat with respect to peripartum cardiomyopathy. We had a great discussion on cardiac complications in pregnancy with valuable inputs from our expert panelists, Dr. Kurunath Parade, Dr. G.S. Wander, and Dr. A. Murugnathan. Dr. Uday Jadhav, the moderator, navigated the discussion well, and I think the take home messages were clear and loud for our attending delegates. Dr. Ashish Nabar, our quiz master for the morning, has always been superb, and he had involved the entire panel in the discussion, which made it really sounding well for the attending delegates. I would feel in my duties if I would not thank Dr. Ketan Mehta, who has been the mastermind behind the entire month schedule for this program, coining a really innovative term, common cardiology course for clinicians, the C4. We had 4 modules: diagnosis of IHD, diagnostic modalities in cardiology, hypertension, and cardiology in pregnancy. Today, we have clocked 810 delegates from Pan India. And just to give a figure, we have 3,162 delegates totally who have joined us over the 4 Sundays on this November month. So, again, great thanks to all the panelists and all the delegates for having joined us on a Sunday morning and for also supporting our COVID patients as usual. Let us all stay indoors, stay safe, stay healthy, and let us all have a great, healthy next year, 2021. Thank you very much.
Thank you.
3 cheers to Dr. Ketan Mehta.
Thank you. Thank you, Muruganathan sir.
Thank you, Ketan. Thank you.
Thank you.
Yeah,